Chair of the Advisory Committee on Immunization Practices. Today is September 11th, September 12th, and I am pleased to call today's ACIP meeting to order. I will turn it over to Dr. Melinda Wharton to begin with our purpose and our process this morning.
Good morning. Thank you, Dr. Lee. Next slide, please. Good morning and welcome to the September 12th, 2023 virtual ACIP meeting. Copies of the slides being presented at today's meeting are available or will be available soon on the ACIP website. A few notes on meeting logistics for those who are listening in on the Zoom line. Please keep your lines muted until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion, Dr. Lee will take questions first from voting ACIP members and then, as time allows, from ex officio and liaison representatives. Please keep your video off until we get to the vote. We'll then ask ACIP members to turn their video on issues coming to ACIP via regulations.gov. The docket number for today's
Advisory
meeting
Committee
is
on
ID
Immunization
CDC
Practices is at its
2023
heart a public body and
0060.
engagement with the public and
Information on the written public comment process, including as well information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, ACIP has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Dr. Lee, that concludes my opening comments.
Thank you, Dr. Wharton. We will move on to roll call and then a few announcements to set the stage for today's discussion. For the ACIP members, I'll ask that you state your name, your affiliation, and whether you have any conflicts of interest. We will start with Dr. Bell.
Good morning, Beth Bell, Clinical Professor, Department of Global Health, University of Washington. No conflicts.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts. Thank you.
Thank you. Dr. Chen.
Wilbur Chen, Professor of Medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health, and Director of the Travel Medicine Practice here at University. I have no conflicts.
Thank you. Dr. Sineas.
Good morning, Sybil Sineas. I'm an Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly.
Good morning, Matt Daly. I'm a general pediatrician and also a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and I have no conflicts of interest. Thanks.
Thank you. Dr. Paling.
Good morning. It's Kathy Paling. I am a pediatrician, professor of pediatrics, epidemiology, and prevention at Atrium Health Wake Forest Baptist Wake Forest School of Medicine. I have no conflict. Thank you.
Thank you. Dr. Talbot.
Good morning, Kip Talbot, Professor of Medicine and Health Policy, an adult infectious disease doctor. Thank you.
Thank you. Dr. Lair.
Good morning. This is Jamie Lair. I'm a private practice family physician in Ithaca, New York, and I have no conflicts of interest.
Thank you. Ms. Bata.
Good morning. This is Lynn Bata. I'm a public health nurse functioning as the immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Ms. McNally.
Good morning, Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Long?
Good morning. I'm Sarah Long, pediatric infectious disease physician and professor of pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict.
Thank you. And this is Grace Lee, professor of pediatrics at Stanford University School of Medicine and chief quality officer at Stanford Medicine Children's Health. I have no conflicts. Let me just confirm, are there any additional ACIP members on the call right now that I haven't called on? Okay. Well, for our committee, we do have quorum today, so we're able to proceed. For our ex officio and liaison members, I will announce the organization name and then please indicate your first and last name on behalf of your organization. We will start with the Centers for Disease Control and Prevention.
Hi there, this is Dimitri Daskalakis. I am representing CDC.
Thank you. Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance representing CMS.
Thank you. Food and Drug Administration.
David Kasla representing Food and Drug Administration.
Thank you. Health Resources and Service Administration.
Commander Reed Grimes representing HRSA.
Thank you. Indian Health Service.
Good morning. Matthew Clark representing Indian Health Service.
Thank you. National Institutes of Health.
Good morning, John Bible, representing the National Institute of Health.
Morning, and thank you. Office of Infectious Disease and HIV/AIDS Policy. Okay, we'll move on to the American Academy of Family Physicians.
Pamela Rockwell, AAFP. Hello.
Thank you. American Academy of Pediatrics. I believe if we have the American Academy of Pediatrics Red Book on.
Yeah, this is Sean O'Leary representing AAP.
Oh, thank you, Dr. O'Leary. And
David,
for the Red Book?
David Kimberlin, AAP Red Book editor.
Thank you. American Academy of Physician Associates.
Good morning, Marie-Michelle Léger.
Thank you. American College Health Association.
Hebi Chai, present.
Thank you. American College of Nurse Midwives. American College of Obstetricians and Gynecologists. American College of Physicians.
Dr. Jason Goldman, representing American College of Physicians.
Thank you. American Geriatric Society.
And Schmader for AGS.
Thank you. America's Health Insurance Plans.
Good morning, Jessica Gra, present.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle, representing ARO.
Thank you. American Medical Association.
Sandra Freihofer, internal medicine physician in Atlanta and adjunct associate professor at Emory representing the American Medical Association.
Thank you. American Nurses Association.
Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association.
Yes, good morning, Stan Grog, present.
Morning. American Pharmacists Association.
Good morning, Kelly Good, representing APHA.
Thank you. Association of Immunization Managers.
Good morning, Shelley Fiskus, representing AIM.
Thank you. Association for Prevention, Teaching, and Research. Association of State and Territorial Health Officials.
Sorry, Catherine Williams, APTR. I missed the mute.
Thank you. Sorry, we're moving quickly. Association of State and Territorial Health Officials. Biotechnology Innovation Organization.
Phyllis Arthur and Emily Acker for Bio. Good morning.
Good morning and thank you. Council of State and Territorial Epidemiologists.
Hello, Paul Cieslak representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Kelsey Young here on behalf of NACI.
Thank you. Infectious Diseases Society of America.
Good morning, Jeff Duchin representing IDSA.
Thank you. International Society for Travel Medicine.
Good morning, Elizabeth Barnett here for ISTM.
Morning, thank you. National Association of County and City Health Officials.
Good morning, Jeff Duchin again representing National Association of County and City Health Officials.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield for NAPNAP.
Thank you. National Foundation for Infectious Diseases.
Bob Hopkins and Marla Dalton for National Foundation for Infectious Diseases.
Thank you. National Medical Association.
Good morning, Pat Whitley Williams for the National Medical Association.
Thank you. Pediatric Infectious Disease Society. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Thank you. Good morning. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman for SAM.
Thank you. Society for Healthcare Epidemiology of America.
Breathing Rocha for Shea.
Thank you. And with that, I'm going to go back and ask Dr. Brooks if he could please state his name, his affiliation, and any conflicts of interest.
Good morning, everyone. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation. I have no conflicts.
Thank you, Dr. Brooks. Are there any additional liaison members who are not able to identify themselves? Okay. Well, thank you very much. Before we get started, I just want to, take a moment to thank my ACIP members and our liaison members and our CDC colleagues for coming together for today's meeting. I may have lost count. I think we are at 34 additional meetings since the pandemic began, but I'm sure someone will correct me on that. But this is a lot of additional work, and I am just very appreciative that everyone takes the time to be able to come join together and have these deliberations for these public meetings. Next, we will take a moment to have a few brief remarks from our colleagues at CDC and FDA to help provide additional context for today's meeting. So first, I would like to introduce Dr. Mandy Cohen, who is the Director of the Centers for Disease Control and Prevention. Dr. Cohen, the floor is yours.
Well, good morning, Dr. Lee. Can you hear me?
Yes, we can. Thank you. Please go ahead.
Well, first, Dr. Lee, thank you so much for your leadership. I also want to thank Dr. Warden for her leadership on the CDC side. I just wanted to join briefly this morning to say thank you. I had an appreciation for your work as Secretary of Health and Human Services for North Carolina, and frankly, as a mom and a wife and a daughter, for all of the work that you have done throughout this pandemic. But now, as the new director of the CDC, I think I have even greater appreciation now for the amount of work that goes into preparing for each and every one of these decisions and recommendations, the amount of work that I know you are going through each and every day, that you're taking time out of your other work that you're doing. I just am so grateful for your service to this committee and to the country. I think you know that your work is critical, but I just wanted to say thank you once again. And we're in such a different place than we were in the beginning of the pandemic, which is wonderful. We're in our strongest position yet to fight COVID-19, as well as flu and RSV this winter season. We have more tools, and I'm excited for the first time ever we have tools against all three of the major virus pathogens. I know you're going to be focused on COVID today, but I know we're coming back to even just next week to focus on RSV. So again, so much time and commitment of this group. I'm just so grateful. I think at CDC, we are centering our efforts around building trust, increasing transparency and communication, and making sure that we're bringing evidence, data, and best practices to bear to protect and improve health across this country and frankly, the world. We are really making sure that we're thinking about sharing simple, clear information with common sense solution and steps that people can take and their loved ones, particularly as we think about this coming fall and winter respiratory season. So we're trying to use all the tools at our disposal to build that trust. And you are a very big part of that work. And so thank you for all that you continue to do. I know today you're going to be hearing a lot of data, and thank you to the teams that have done the scientific work, to the teams of the CDC that have been putting this together and working side by side with the work groups and others, and Dr. Lee, again, for your leadership. You're going to see data that goes through all the benefits and the risks of these updated COVID-19 vaccines, and this is going to include comparison of the burden of COVID-19 hospitalization to other vaccine preventable diseases like flu. You're also going to hear about recent trends on the rates of COVID hospitalizations. As you know, we're already in the midst of an increase in hospitalizations for COVID-19. And this virus continues to keep us humble. It has continued to change. And we have been working hard with many partners across the healthcare ecosystem to make sure we can continue to stay ahead and give folks the most tools that they can to protect themselves. You know, I know that this group has such a deep understanding of the U.S. immunization program and how important it has been to improving and protecting health for decades. And again, I know that's going to be brought to bear here as we look at some of the additional ways in which we've used universal vaccine recommendations, such as in flu and others, to make sure that we're preventing diseases. So just to wrap up here, I so value the expertise of this group and your ability to synthesize all of these different kinds of considerations. There are different data inputs that you're looking at and the context that you're looking at it. Let me just leave you with the things that are the most important to me as you go into the day. One, that we together are able to communicate clearly and effectively to the public about this vaccine, right? So again, going back to that trust, we want to make sure that we are able to communicate clearly and effectively to the public about this vaccine. So thank you for that. And then secondly, what's important to me is that we're able to make this vaccine available in an equitable way so that folks have equitable access to this important tool. So again, the communication about clear and effective communication and equitable access. So those are the two things on my mind. And I know you're going to get into your work today again. And I so grateful for everything that you are doing and the time that you're giving to this work. So I'll turn it back over to you, Dr. Lee, to get to work and again, thank you so much for your service.
Well, thank you so much for joining us this morning, Dr. Cohen. We really appreciate it and appreciate your comments. With that, we will move on to Dr. David Caslow from the FDA. He is the director of the Office of Vaccines Research and Review in the Center for Biologics.
Thank you, Dr. Lee. And let me echo from the FDA, Dr. Cohen's thanks to ACIP and the CDC. So yesterday, FDA took 4 regulatory actions on mRNA-based COVID-19 vaccines, 2 approvals and 2 authorizations. Both of the mRNA vaccines that were previously approved in the United States were updated to approve a single-dose regimen in individuals 12 years of age and older. That single-dose regimen is now approved for the 2023-2024 formula that includes a monovalent or a single component encoding the viral spike glycoprotein of SARS-CoV-2, Omicron variant lineage XBB.1.5. Section 8.6 of the prescribing information, titled Immunocompromised Individuals, notes that the Centers for Disease Control and Prevention has published considerations related to COVID-19 vaccination for individuals who are moderately to severely immunocompromised. FDA also authorized yesterday both mRNA vaccines, which were previously authorized in the United States for a bivalent COVID-19 vaccine in individuals 6 months to 11 years of age. Both of those mRNA vaccines are now monovalent 2023-2024 formulas and are now harmonized for a single dose regimen in individuals 5 years through 11 years of age, regardless of previous vaccination status. Unvaccinated individuals 6 months through 4 years of age continue to be eligible to receive 3 doses of the now updated authorized Pfizer-BioNTech COVID-19 vaccine, or 2 doses of the now updated authorized Moderna vaccine. Individuals 6 months through 4 years of age who have been previously vaccinated against COVID-19 are eligible to receive 1 or 2 doses of a now updated mRNA vaccine, the timing and number of doses depending on the number of previous COVID vaccine doses received. Finally, additional doses of the updated mRNA vaccines have been authorized for individuals 6 months through 11 years of age with certain kinds of immunocompromised. These 6 month to 11-year-olds should complete, or 2-year-olds should complete at least a 3-dose series with an age-appropriate dose and dosing schedule of a COVID-19 vaccine. And at least one of those doses should be a COVID-19 vaccine 2023-2024 format. And with that, I'll turn the floor back to you, Dr. Lee.
Thank you very much, Dr. Kessel. I just wanted to take a moment to thank you for your work at the FDA to ensure that the regulatory actions are easier to implement, especially for our children. Before we move on to the last set of comments, we have received a lot of requests for information around the Novavax vaccine. I know you may not be able to comment on that, but is there anything you can tell us from the FDA?
Sure, no, thank you for that question. So with respect to other COVID-19 vaccines, as you pointed out, I'm not at liberty to disclose or discuss if, what, or when a submission has been made to FDA. However, a sponsor applicant is always free to do so. What I can say, both from the office and from CBER, is, and what we've said repeatedly is, and what we heard from VRBPAC both in January and June, is that there is an urgent need for alternatives to mRNA-based vaccines, including protein-based vaccines. And so in that regard, we will review such a submission expeditiously. I also wanted to point out that FDA co-hosted a workshop with BARDA on this topic in April this year, in which challenges, including the time needed to update vaccine composition of protein-based vaccines, were discussed. And what I would say is really for any additional information on this topic, I would kindly defer to the sponsor. So with that, I'll turn it back to you, Dr. Lee.
Thank you, Dr. Kessler. We appreciate that. We have one additional comment. Introducing Dr. Dimitri Daskalakis, who is heading up or leading NCIRD from the CDC. So Dr. Daskalakis, would you like to make a few comments?
Thank you so much. And great to be here in my new acting status as the NCIRD director. So again, I'm really excited to be here and to sort of hear the process that ACIP has gone through. I'll echo Dr. Cohen and her comments about just the great amount of work that goes into this and just the gratitude we have for all who serve on the committee to make sure that we are continuing to look at the data so that we can best serve the people of America and their health. I think otherwise, I would probably hand it right back over to you so we can. Specifically a Novavax comment? No problem. So just on follow-up to that, so thanks to the FDA comment. So again, I'll echo that we're also aware that there's a lot of interest in having non-mRNA vaccine options available. And we also look forward to the potential authorization of the updated vaccine. It's important to note that the voting language that is going to be presented later today is inclusive of FDA licensed or authorized updated monovalent XBB containing COVID-19 vaccines, including those that may be licensed or authorized in coming months. So this would allow such vaccines to be incorporated into programs immediately following FDA regulatory action, and that won't require that ACIP be reconvened. So I hope that this will facilitate the availability of the Novavax vaccine once FDA has reviewed and potentially authorized. Thank you.
Thank you so much for your comment. With that, I believe we are ready to move on to our first session for today, which I'm going to turn it over to Dr. Matt Daly, who is chair of the COVID-19 Vaccines Working Group, to provide an introduction and overview of today's session.
Thanks very much, Dr. Lee. Good morning, everyone. I'll be introducing the session today on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. So as we just heard from Dr. Kaslow, FDA had a number of authorizations and approvals yesterday. He summarized those so clearly, but just to reiterate a couple points, FDA updated the COVID-19 vaccine emergency use authorizations, or EUAs, yesterday for the use of 2023-2024 mRNA vaccines for all doses and indications administered to individuals ages 6 months to 11 years. In addition, the FDA approved supplemental biologic license applications, or BLAs, for the use of 2023-2024 mRNA vaccines for all doses and indications administered to individuals ages 12 years and older. Next slide, please. So I did want to review what we discussed at the most recent public ACIP meeting on June 23rd of 2023. At that meeting, we heard a number of updates, including to COVID-19 epidemiology and vaccine effectiveness among pregnant persons and infants. We also heard and had a detailed discussion about infection-induced and hybrid immunity. And then following this, we summarized sort of the material presented in a number of workgroup considerations with respect to COVID-19 and pregnancy. Pregnancy remains a risk factor for severe COVID-19 disease. And based on the available data, COVID-19 vaccination substantially improves outcomes for pregnant people and their infants. And then in the context of infection-induced immunity and hybrid immunity, the summary of what was presented there includes the following. Hybrid immunity likely does provide better protection than either infection or vaccination alone. However, protection is likely influenced by multiple factors, including prior vaccine doses, prior infection, time since vaccination or infection. But it's important to highlight in the context of our discussion today that protection wanes over time following infection and following vaccination. Next slide, please. So then to review the deliberations of the ACIP COVID-19 Vaccines Work Group between that meeting and today. During that time, we've met frequently. We have been meeting almost weekly, and in that time we reviewed manufacturer data to inform monovalent XBB.1.5 containing vaccines. We reviewed the modeling of pandemic outcomes in a variety of scenarios. And what this did was look at potential impact of new variants and potential impact of different vaccine and booster coverage on the pandemic outcomes in these various scenarios. We heard a comprehensive review of COVID-19 vaccine safety, and we'll hear that again today. We then received updated data on COVID-19 epidemiology, vaccine effectiveness, and benefit risk assessment. In addition, we heard additional detail about the epidemiology of post-COVID conditions. We'll also hear some of that today in public session. And then we heard COVID-19 vaccine cost effectiveness analyses. And when I say heard, of course, I mean we sort of had a detailed discussion after presentation about that as well. And then this all led up to our review of the evidence to recommendations framework, which we're also going to hear in detail today. including that the work group discussed universal vaccination recommendations versus risk-based strategies, and requested and then reviewed additional data on burden by age group and by presence of underlying condition. Next slide, please. So the agenda for today is as follows. We'll first hear from Dr. Thornburg, who will review the current landscape of SARS-CoV-2 lineages. Then we'll hear from Dr. Havers, who will review COVID-19 epidemiology. Following this, we'll hear from Dr. Saida, who will review post-COVID conditions with us. Following this, we will hear from Dr. Link Gellis, who will review COVID-19 vaccine effectiveness. Following this, we'll hear from Dr. Prosser, who will review an economic analysis of COVID-19 vaccination. And then following this, we'll hear from Dr. Klein, who will review COVID-19 vaccine safety surveillance. I think at this point, we'll all take a breath and then take a break. And then after this, we will hear from Dr. Priddy at Moderna, who will review Moderna's 2023-2024 COVID-19 vaccine. We'll then hear from Dr. Dubovsky from Novavax, who will review Novavax's 2023-2024 COVID-19 vaccine. And then after this, we'll hear from Dr. Mojarid, who will review Pfizer BioNTech 2023-2024 COVID-19 vaccine. Next slide, please. Following this, we'll have a break, and then we'll hear from Dr. Wallace, who will review the evidence recommendations framework for the use of COVID-19 vaccines. Then we'll hear from Dr. Peacock, who will provide an overview of important considerations around COVID-19 vaccine implementation. And then we'll hear from Dr. Twentyman, who will review the Bridge Access Program. Following this, we'll have a discussion, and then a break, and then a public comment, and then a break, and then we will vote on the use of 2023-2024 COVID-19 vaccines in persons ages 6 months and older. Next slide, please. So my sincere thanks to the ACIP COVID-19 vaccines workgroup members who spent countless hours reviewing everything that I presented so far today. So this includes ACIP members, ex officio and government members, the CDC leads, Dr. Wallace and Dr. Reagan. In addition, we have a number of liaisons who critically contributed to this, and a number of consultants. Next slide, please. And then there's a number of CDC participants who, again, are working countless hours to provide the data for which we are deliberating, or on which we are deliberating. Next slide, please. Thanks. I pass it back to you, Dr. Lee.
Thank you, Dr. Daly. We will take a moment to recognize our ACIP member, Pablo Sanchez. If you could please just state your name, your affiliation, and if you have any conflicts.
Thank you, Grace. Pablo Sanchez, a professor of pediatrics at the Iowa State University School of Medicine. And I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital in Columbus, Ohio. And I have no conflict. Thank you.
Thank you. With that, we'll move on to Dr. Natalie Thornburg, who will discuss the current landscape of SARS-CoV-2 lineages.
Thank you, Dr. Lee. Can you hear me okay?
Yes, we can. Please go ahead.
Great, thanks. Next slide. So I'm going to talk to you today about the current landscape of circulating SARS-CoV-2 lineages. This is our weighted estimate and nowcast predicted estimates of currently circulating viral lineages. Just a reminder on how you look at these kind of graphs. On the left side of the graph are weighted estimates. They're variant proportions based on reported genomic sequences. So these are generated from actual sequencing results. And then along the x-axis on the bottom are the bi-week periods that we report the data. So 2 week, the data are bucketed into 2 week bins. And then we use those weighted estimates, the actual sequences generated, to model into the present. And we do that because it takes at least 2 weeks for sequences, for specimens to make it from diagnostics labs to sequencing labs and then complete the sequencing workflow and analysis. So we have to model into the present tense. So on the right side of the graph, you see the nowcast model, with the most recent update having occurred on September 1st, and there will be another update that posts at the end of this week where we don't expect any dramatic differences from what was posted about a week ago. And so this looks like there's a lot of viral diversity at the moment, but there actually is less viral diversity than all of these colors indicate. All of these viruses and all of these prevalent viruses are XBB lineage viruses, except for some of the ones listed at the very, very bottom of the list on the right. But those you'll see the proportions are 0 to 0.1% of viruses. So really everything that is circulating currently in any significant proportion are XBB lineage viruses. They look very different because of the use of aliases. So once a viral lineage gets added a lot of numbers onto it, an alias is assigned, and that is a letter with a number. And those aliases are assigned just in order. So they're not linked back to that original name. So EG5, which is the most predicted to be the most prevalent circulating lineage right now, is an XBB lineage virus. Now, I mentioned the diversity is less than what this appears. Many of these lineages actually have identical spike sequences. We've observed this before, where we see convergent evolution in viruses evolving to have the same substitutions in spike via multiple different lines of evolution. And I'll show you that 2 slides from now. So take-home message is, currently, almost all circulating lineages of viruses are XBB lineage viruses. Next slide, please. I showed this slide at VRPAC in June. And so we see some differences now. I'm going to show you what I showed in June, and then in the next slide, I'll show you viruses that are circulating currently. These are substitutions that were observed in the receptor binding domain portion of spike in comparison to BA4, BA5 spike sequence. So as a reminder, the receptor binding domain is the portion of the spike protein that binds to the cellular receptor, ACE2. So that's sort of the most important target for neutralizing antibodies is the receptor binding domain. So substitutions in that area are most likely to generate reductions in neutralizing antibody responses. So these are all anchored to BA4, BA5 spike sequence because that was the formulation of Omicron that was included in the bivalent booster last year. These were viruses that circulated from September 2022 to June of this year, 2023. And at the time, the viruses that were increasing in proportion were bolded. So you can see them at the bottom of this table. And what I want you to see is slow but definite accumulation of substitutions in the receptor binding domain that likely led to incremental reductions in neutralization over the course of the year. Next slide. Now this is a very similar slide, but with currently circulating viruses. So not going all the way back to September 2023. This is what's circulating right now. And this is anchored to the reference sequence XBB.1.5, since that is the proposed formulation of updated COVID-19 vaccinations. And so the sequence of each place where we're seeing some substitution is listed on the top. That's what's in XBB.1.9. You can see fewer columns, and that just means we're seeing fewer substitutions in currently circulating viruses in comparison to the vaccine formulation, XBB.1.5. And in currently circulating viruses, you'll see 1 to 2 substitutions in the receptor binding domain. So not a lot of substitutions in the receptor binding domain. You will see consistently, we are seeing a lot of the currently circulating viruses, especially those that are increasing in proportion, which are bolded, have an F to L substitution at residue 456, maybe indicating that the viruses are finding some sort of advantage by evolving this substitution. Next slide, please. And this was a slide I showed at VRPAC in June. At the time, there was consideration of either utilizing an XBB.1.5 formulation of vaccine or an XBB.1.6 formulation of the vaccine. This is a crystal structure of spike shown sort of on the bottom in gray. One protomer, or one piece of the three-part trimer of spike, is colored with the different portions of spike colored differently. Receptor binding domain is red and green, with the motif is a smaller portion of the receptor binding domain that really directly abuts ACE2. ACE2 would be attached to the cell. That's the cellular receptor up there on the top, kind of in gold. And the substitutions in those XBB viruses in comparison to BA.5 spike are in squares. And then there were two differences between these two proposed vaccine strains that are highlighted in green, one in the receptor binding motif and one in the N-terminal domain, which is blue. So they are very, very, very similar spike sequences, XBB.1.5 and XBB.1.16. Next slide, please. All right, so those viruses that I just talked through are greater than 90%, really closer to 99% of circulating viruses are all of those XBB lineage viruses that have one or two substitutions in comparison to XBB.1.5. I'm going to go through a couple of slides talking about BA.2.86, just because it's garnered a lot of attention and a lot of attention recently because it is very different than XBB lineage viruses. So this was first detected in early August, I believe, and it is a lineage of virus that's actually most closely related to BA.2. BA.2 is an Omicron that precedes XBB viruses. XBB viruses are BA.2 lineage viruses, but they're chimeric viruses, and so this seemed to have evolved independently of XBB lineage viruses and is quite different than XBB lineage viruses. So BA.2 and its lineages circulated in the spring of 2022, before the BA.5 wave, which happened late last summer, early last fall, after the really big Omicron wave, which was BA.1 lineage viruses in December, January, February of 2022. So it was sort of March, April, May, circulation in the US when we actually didn't have a whole lot of cases of COVID-19 at that time. So you can see a phylogenetic tree on the bottom left that was pulled from next strain and a blow up of all the sequences that have been generated on the right. And there's it's kind of evolving in two different, I don't want to say clades, but two different versions of BA.2.86 right now. There are two US sequences that are highlighted with yellow errors. So one that was detected in Michigan and another sequence that was detected in Ohio. Next slide, please. So BA.2.86 has more than 30 amino acid substitutions in spike in comparison to XBB.1.5. And as far as the sequencing goes, that's a similar change in amino acid of spike during that Delta to Omicron shift. There's variations between sequences due to missing data and sequencing artifacts, but then there also may be some variations in some of the viruses themselves. Again, it was first detected in specimens collected in late July 2023. And as of last week, there were seven clinical specimens, 7 sequences in 7 US states, and then there was 1 additional state detections in wastewater. We may have a couple more this week and in coming weeks, but the take-home message is we have a very small number of viruses detected in the United States thus far. And as of last week, it had been detected in 10 different countries. We're still dealing with a fairly small number of sequences. I do want you to look at the alignment on the top. The alignment is not just the receptor binding domain. The receptor binding domain is shown in red. This is substitutions represented across the whole spike protein, and terminal domain being in blue, receptor binding domain in red, and S1, S2 interface in purple and sort of peach colored. The top is BA.2, the descendant or the parental lineage. The second line is XBB.1.5, the proposed current formulation of the vaccine, and then the bottom two are BA.2.86 sequences, substitutions. And what I want you to see is just there's a large number of substitutions in BA.2.86 in comparison to XBB.1.5. Next slide. So because of this large number of substitutions, there is some concern that there could be a more dramatic reduction in neutralization against BA.2.86 viruses should they take hold and increase in proportion, which they have not done yet, and we cannot say with certainty is going to happen. So many labs have now generated data for neutralization. I'm going to show two studies, but there have been more studies. There's more studies posted every day for neutralization. This study is out of David Ho's laboratory. This is generated through the SAVE network, which is a network of laboratories that's funded with our SARS interagency group partner, or SARS interagency group partners at NIAID. So this is pseudovirus neutralization. So it's not in a SARS-2 backbone. You use a different virus backbone and put spike on the surface of it and see just sera how much virus can be neutralized by different kinds of sera. So in the left panel is 3 shots original vaccine formulations and 2 shots of last year's vaccine formulation. The middle panel are from convalescent sera for persons who had BA.2 infections, and on the right panel are convalescent sera from persons who had infections with XBB lineage viruses. And the message I want you to look at here is sort of the bottom 2 columns in each graph are 2 BA.2.86 viruses. And there is still good neutralization of BA.2.86 viruses, pseudoviruses, in comparison to XBB.1.5 virus, using really all of the different types of sera. And so even though there could have been a reduction in neutralization because the virus is so different, the laboratory is just not observing a reduction in neutralization. Next slide. Similar type of experiment done also supported by the SAVE network and our SARS interagency group from Dan Baruch's laboratory, also pseudovirus neutralization. These are persons who received the vaccine formulation from last year. Shortly after vaccination, that's what baseline is in the left panel. 6 months after vaccination in the middle panel, and then 6 months after vaccination from people who also had an XBB infection. And very similar to Dr. Ho's laboratory data, if you look at the far right-hand columns of this graph, if it's BA.2.86, it's in red. They did not observe a dramatic reduction in neutralization of BA.2.86 pseudoviruses in comparison to XBB.1.5 viruses. Although, of course, this is with people who have received last year's formulation of vaccine in baseline on the left, and those who had had an XBB infection on the right. And in reality, they actually saw a little bit higher titers against XBB or BA.2.86 pseudoviruses. So there have been, since these 2 studies have been posted, there have been a couple other studies posted. One is with recombinant viruses. So it's an authentic, well, it is a full SARS-2 virus, not in the backbone of another virus, but was generated in the laboratory, and they observed similar results with no dramatic reduction in BA.2.86 neutralization. Next slide, please. So as a reminder, more than 90% of circulating viruses are XBB lineage viruses with an additional 1 to 2 substitutions in RBD. Oh, I'm sorry. This slide is not correct, but okay. More than 90% of circulating viruses are XBB lineage viruses with 1 to 2 additional substitutions. BA.2.86 is a newly detected lineage with 30 amino acid substitutions in spike. Thus far, the number of viruses detected is still low. Sequence numbers are too low to calculate proportion though. So we don't know if BA.2.86 will be of any significant circulation. Preliminary pseudovirus neutralization data generated by multiple labs do not indicate a large reduction in neutralization activity. We have, and I apologize, these slides got swapped during reviews. We have, CDC has generated 2 authentic isolates of BA.2.86, one confirmed and one putative. We are in the process of distributing BA.2.86 viruses to multiple labs to do transmission studies, more neutralization studies against lots of different kinds of sera. And then we have another putative isolate, which is from a slightly different version of BA.2.86. We're also locally working on titrations before neutralization studies. And I believe this is my last slide. Next slide. Yeah, sorry. Okay, that's all. Next slide. Take any.
Thank you, Dr. Thornburg. We appreciate the detailed presentation and also just how you shared the sort of dynamic changes of the virus itself. We're going to move on to the next presentation, and we will take questions after a series of presentations. We'll move on to Dr. Fiona Havers, who will discuss COVID-19 epidemiology.
Great, thank you, Dr. Lee. So my name is Fiona Havers, and I'm going to be talking today about COVID-19 associated hospitalizations among infants, children, and adults, primarily using data from the COVIDNet network and focusing on data from this year, from January through August 2023. Next slide. COVIDNet is one of 3 platforms that comprise the ResMed surveillance network. FluSurvNet, another ResMed platform with very similar surveillance methods, will be used in several slides later on to provide comparisons between COVID and influenza-associated hospitalizations.
Dr. Havers, apologies. Could you get a little closer to the mic? Our members are having a hard time hearing you.
Oh, okay. Is that any better?
Much better, thank you.
Okay. All right, so I think many of you are familiar with COVIDNet, but as a reminder, COVIDNet collects data from more than 300 acute care hospitals in 98 counties in 13 states. The COVIDNet catchment area includes about 10% of the U.S. population. And hospitalizations reported to COVIDNet include all those where a positive SARS-CoV-2 test result was reported within 14 days prior to or during hospitalization. And testing for SARS-CoV-2 is driven by clinical judgment and facility policies. So data on rates and basic demographic data are collected on all patients, and then clinical data are collected from an age and site stratified representative random sample. Next slide. This slide shows 2 figures. The left figure shows weekly rates of COVID-19 associated hospitalization among all age groups from March 2020, near the beginning of the pandemic, through August 26, 2023. The figure in the red box is at the same scale as the figure on the left, but includes only data from the most recent 8 months from January through August 2023. Please note that hospitalization rates have been rising steadily since mid-July. In the last 6 months, rates among adults ages 75 years and older, indicated by the dashed purple line, have remained elevated relative to all other age groups. Rates among infants less than 6 months, which is indicated by the solid gray line, are similar to rates among adults ages 65 to 74 years, shown in teal. Next slide. So I'm now going to talk specifically about COVID-19 associated hospitalizations among children. Next slide. So this is a similar graph from what we just saw, just showing pediatric age groups in those 17 years and younger. The solid red line are rates among infants less than 6 months. Hospitalization rates in this age group are markedly higher than in other pediatric age groups. Next slide. Because we are focusing today on vaccine-eligible age groups, this figure is similar, but with the rates of infants less than 6 months removed. After infants, the age group with the next highest rates of COVID-19 associated hospitalization are infants and children ages 6 to 23 months, with lower rates in children ages 2 to 4 years, 5 to 11, and 12 to 17 years. Next slide. So this slide shows the prevalence of underlying medical conditions by age group among children hospitalized with COVID-19. Overall, 54% of pediatric patients had no underlying medical conditions, but this varied widely among age groups. Generally speaking, most infants and very young children who were hospitalized had no underlying medical conditions, and those who did, among those who did, prematurity was the most frequently observed. The proportion of children hospitalized for COVID-19 who had underlying medical conditions increased with increasing age, with asthma, the yellow column, neurologic disorders in bright teal, and obesity in purple, being the most frequently observed conditions in older children and adolescents. Note that neurologic disorders is an interesting observation, as the population prevalence of neurologic disorders is far lower than the proportion seen among children hospitalized for COVID-19. Next slide. So to put COVID and hospitalization rates in context with another vaccine-preventable disease, these two figures provide comparisons of COVID-19 and influenza-associated hospitalizations using data from COVIDNet and FluSurvNet. Note that active surveillance for FluSurvNet for the most recent season occurred during a typical respiratory virus surveillance period of October through April, whereas COVIDNet hospitalization surveillance remains year-round. So these figures compare cumulative hospitalization rates for COVID and flu for the two most recent surveillance seasons. For the 2021-22 season, which runs from October 21 through September 22, and the figure on the left, rates of COVID hospitalizations indicated in the solid color lines were higher for all the 3 pediatric age groups shown relative to influenza hospitalizations, represented by the dashed lines. In comparison, for the 2022-23 season, which started in October 2022, hospitalization rates for COVID-19 were lower in all age groups compared to the previous season, and rates for influenza were higher or comparable for these pediatric age groups. Note that these rates include all patients admitted with a positive SARS-CoV-2 test and do not take into account reason for admission. In the older pediatric age groups, particularly those 12 to 17, some adolescents who were admitted with a positive SARS-CoV-2 test were admitted primarily for other reasons. So this likely happens more frequently for COVID than for influenza, and that maybe should be taken into account when comparing rates for COVID-19 and influenza in this most recent season. Next slide. In this final figure, comparing flu and COVID hospitalizations among infants, children, and adolescents, the proportion of hospitalized patients admitted to the ICU by pathogen and age group were compared. A higher proportion of COVID-19 hospitalizations were admitted to the ICU relative to influenza hospitalizations, but as you can see, both pathogens cause severe outcomes in all age groups. Next slide. And this figure shows the proportion of COVID-19 associated hospitalizations by vaccination status among the vaccination-eligible pediatric age groups for January through June 23. Among children 6 months to 4 years, and for those 5 to 11 years, a significant proportion of hospitalizations are among unvaccinated children, shown in orange. Only 4% of hospitalized children ages 5 to 11 years had received a bivalent booster in this time period, or prior to this time period. Hospitalized adolescents ages 12 to 17 years were less likely to be completely unvaccinated. However, as you can see, only 6% of those hospitalized had received the recommended updated bivalent booster dose. Next slide. I'm now going to transition to talking about COVID-19 associated hospitalizations among adults. Next slide. Again, this slide shows two figures covering similar time periods from what we saw earlier, but only including adult age groups. As noted previously, rates have been climbing steadily since mid-July. And rates among adults ages 65 years and older remain above those experienced in late June 2021, before the transition to the Delta period, the period of Delta variant predominance. It is notable that the oldest adult age group, those 75 years and older, have hospitalization rates that are consistently 2 to 3 times as high as those in the next youngest age group. adults ages 65 to 74 years, indicated by the solid yellow line. Next slide. This figure shows the most common underlying medical conditions among adults by age group for COVID-19 associated hospitalizations between January and June 2023. In general, the distribution of underlying medical conditions that are most common in adults ages 60 to 49 or ages 18 to 49 differ from those seen among adults ages 50 years and older. Among younger adults ages 18 to 49, the most common underlying conditions include obesity, neurologic disorders, cardiovascular disease, asthma, diabetes, and chronic lung disease that does not include asthma. Among the other two age groups, those 50 to 64 and those 65 years and older, the most common underlying medical conditions include cardiovascular disease, obesity, diabetes, neurologic disorders, and also chronic lung disease, including COPD and renal disease. The overall prevalence of these conditions is higher in adults over age 50 relative to adults ages 18 to 49. And substantial proportions of hospitalization among all three adult age groups are reported of having more than three or more underlying medical conditions, including 59% of adults 18 to 49. Next slide. This slide displays figures that compare weekly cumulative population-based rates of COVID and influenza-associated hospitalizations using COVIDNet and FluServeNet platforms, respectively. And this is just for the most recent season from October 2022 through July 2023. Again, COVID-associated hospitalization rates are represented by solid lines, and rates of flu hospitalizations are represented by dashed lines and are matched by color within age group. For the current season, or this most recent season over the last year, among all adult age groups, cumulative rates of COVID-19 associated hospitalizations were higher relative to flu hospitalizations. And please also note that the vertical axis on the two graphs are very different, and that rates are far higher in the adults ages 65 years and older on the right compared to adults ages 18 to 64, which are shown on the left. Next slide. In this figure, it compares flu and COVID-19 associated hospitalizations among adults. The proportion of hospitalized patients admitted to the ICU by pathogen and age group are compared. Note that while the proportion admitted to the ICU varies a bit by age group and pathogen, and may be marginally higher for COVID-19 compared with influenza in some age groups, both pathogens result in ICU admission for a substantial proportion of patients in all adult age groups. I will also note that the previous slide showed that rates of COVID-19 and flu can vary by age group. It's important to remember that while the proportions of severe outcomes, like ICU admission, may be similar between pathogens, age groups with higher rates of hospitalization and a larger number of hospitalizations would result in increased burden of hospitalizations with severe disease, even with similar proportions of those outcomes. Next slide. This is a similar slide that shows the proportion of flu and COVID-associated hospitalizations among adults that result in in-hospital death by pathogen and age group. Among adults, a somewhat higher proportion of COVID-19 hospitalizations died in hospital relative to influenza in most age groups. But again, the results are very similar in both pathogens. Next slide. This figure shows the proportion of COVID-19 associated hospitalizations by vaccination status among adult age groups for January through June 2023. The percent of hospitalized adults who were unvaccinated, indicated by orange, decreased with age, with 35% of adults ages 18 to 49 who are hospitalized or unvaccinated, compared with 11% of hospitalized adults 75 years and older who remained unvaccinated. However, less than 25% of all hospitalized adults in all age groups had received the recommended updated bivalent booster dose, indicated by yellow. For adults 65 to 74 years and also 75 years and older, 81% of hospitalized patients had not received an updated bivalent booster, despite its availability in the fall of 2022, well before the period of hospitalization shown on this graph. So in summary, next slide. Hospitalization rates have increased in all age groups since mid-July. Hospitalization rates remain highest in older adults and in young infants less than 6 months of age. Most children under 5 hospitalized with COVID-19 illness have no underlying medical conditions. A higher proportion of hospitalized children and adolescents in older age groups, those 5 to 17 years, have underlying medical conditions. And Not surprisingly, most hospitalized adults have multiple underlying medical conditions. COVID-19 continues to cause severe illness, with a substantial proportion of patients being admitted to the ICU in all age groups. And clinical outcomes, while it varies a little bit by age group, are generally comparable to influenza-associated hospitalizations. And most children and adults hospitalized for COVID-19 since January 2023 had not received a bivalent booster prior to hospitalization. Next slide. I'd like to thank a number of people, including my colleagues in the coronavirus and other respiratory viruses division, as well as my FluServNet colleagues in the influenza division, and of course, all of the ResMed site investigators and staff who helped generate these data. So thank you very much.
Thank you very much, Dr. Havers. I'm going to ask our members just hold their questions, but please click them up. We're going to move on to Dr. Sharon Saida for a presentation on post-COVID conditions.
Thank you. Great. I'm Sharon Saida. I'm going to be providing an epidemiologic update on the characteristics of long COVID. Next slide. So to start, I wanted to give everyone a general framework for post-COVID conditions. Post-COVID conditions refers to a wide range of physical, mental health consequences that are present 4 or more weeks after SARS-CoV-2 infection. These conditions occur for patients with severe disease and also for patients who had mild or asymptomatic acute infection. On the left are processes that are more specific to infection with SARS-CoV-2 and include new or newly identified neurological conditions, kidney damage or failure, diabetes, cardiovascular damage, or skin conditions. And also symptoms that might have an unclear pathology that include a range of problems lasting for months after the acute infection. And these include symptoms similar to ME/CFS, dysautonomia, POTS, or other post-infectious syndromes. It also includes ongoing symptoms following MIS-C. On the right are conditions that can occur as a result of any severe illness or hospitalization or treatment, such as post-intensive care syndrome. These conditions and symptoms frequently overlap, and patients may experience any combination. Also, please note there are many terms used to refer to post-COVID conditions, with long COVID being the most common and commonly used by the general public. The term PASC, or post-acute sequelae of SARS-CoV-2, often refers to direct pathological effects of the virus. And throughout this presentation, I'll use post-COVID conditions and long COVID interchangeably. Next slide. I'm next going to talk about what we know about the occurrence of post-COVID conditions. Next slide. To start, I wanted to show data from the National Health Interview Survey. This is from 2022, and it provides prevalence estimates of long COVID across all age groups in the US. Here, long COVID is defined as ever or currently reporting symptoms lasting at least 3 months following report of a positive COVID-19 test. And these estimates are among all respondents, so they represent the general US population. From this figure, you can see that the prevalence of long COVID increases with age. Ever having had long COVID is less than 2% among those under 18 years, and currently having long COVID is less than 1% in this age group. Among adults, we see the highest prevalence among adults 35 to 49 years, with 9% ever reporting long COVID and 4.7% currently reporting long COVID. Next slide. Using a similar question as is used on the National Health Interview Survey that I just presented, CDC and the US Census Bureau conduct an internet-based survey every 2 weeks among US adults to look at ever reporting and currently reporting long COVID. Based on this survey, the percent currently reporting long COVID has declined from June of 2022 to January of 2023, and has since remained steady from January of 2023 to June of this year. However, approximately 1 in 4 adults who currently report having long COVID report that it includes significant activity limitations. And this proportion has not changed in the past year. Next slide. In addition to reporting ongoing symptoms, long COVID or post-COVID conditions also includes incident conditions following acute SARS-CoV-2 infection. Using large electronic healthcare data to compare those with COVID-19 to those without COVID-19, we have found that there was an increased risk for 4 symptoms and 8 conditions among children who had COVID-19, and this included an increased risk for heart conditions, kidney failure, blood clots, and diabetes, and neurological conditions. In addition, among adults who had COVID-19 compared to those without COVID-19, there was an 1 in 5 increase, or 1 in 5 adults had a health condition that might be related to their previous COVID-19 infection. And these included neurological or mental health conditions, kidney failure, musculoskeletal, cardiovascular, respiratory conditions, or blood clots and vascular issues. Next slide. The symptoms and conditions of long COVID can persist for months or years after acute infection and may also emerge or reemerge over time. In a prospective study of adults testing positive or negative for COVID-19 who all had acute COVID-19-like illness, we found that ongoing symptoms decreased after 3 months, but approximately 16% continued to experience ongoing symptoms at 12 months. Many of these adults reported new emerging or re-emerging symptoms at 6, 9, and 12 months following the acute COVID-like illness. And of note, these symptoms were not unique to SARS-CoV-2 infection. In a recent publication from the Veterans Affairs patient population, they found that post-COVID conditions also decreased 90 days after acute COVID-19, but did find an increased risk of new conditions continuing for up to 2 years following COVID-19 illness. Next slide. Some of the groups that are more likely to experience post-COVID conditions include female sex, older age sometimes. Adolescents have a higher likelihood of post-COVID conditions compared to younger children. Middle-aged adults compared to younger or older adults are more likely to report symptoms, whereas older adults compared to younger adults are more likely to have incident conditions. Severity of COVID-19 illness increases the likelihood of developing long COVID, as does having underlying health conditions prior to COVID-19. And those with lower socioeconomic status may also be at an increased risk for having long COVID. And finally, those who did not get a COVID-19 vaccine have an increased likelihood of developing long COVID. Next slide. And that is what I'm going to present data on next. Next slide. So this first study is a recent systematic review and meta-analysis that included 6 studies from Italy, Turkey, the United Kingdom, and the United States. Looking at a 2-dose COVID-19 vaccination, this was associated with a lower frequency of long COVID compared to no vaccination, with an odds ratio of 0.64. And a 1-dose vaccination was also associated with a lower risk compared to no vaccination, with an odds ratio of 0.6. However, a 1-dose vaccination compared to no vaccination was not significantly associated with a lower frequency of long COVID. And these results included post-COVID conditions defined both by a self-report of ongoing symptoms and the incidence of new conditions from electronic health records. Of note, these studies summarized here only included adults. Next slide. These are results based on unpublished data looking at the association of prior vaccination status with post-COVID conditions among 161,000 vaccinated patients matched to unvaccinated patients within 7 days of a SARS-CoV-2 positive test, and then further matched by age, sex, and severity of infection. This figure presents the relative risks adjusted for those variables along with race, ethnicity, comorbidity, influenza vaccination, and healthcare utilization. Compared to unvaccinated individuals, vaccinated individuals had the same or lower risk of post-COVID conditions, and many of these associations were stronger in the younger age groups. Next slide. This next slide presents data from our Heroes Recover cohort, vaccine effectiveness cohorts. Participants in this cohort collected mid-turbinate nasal swabs weekly, regardless of illness or symptoms, and then had additional swabs collected for any illness symptoms. This study utilized a case control design where participants who tested positive for SARS-CoV-2 were then asked about post-COVID conditions at least 60 days after testing positive. After adjustment for gender, age, number of chronic conditions, and the number of symptoms during the acute infection, having a 3-dose mRNA vaccine at least 7 days prior to infection reduced the odds of the occurrence of post-COVID conditions with an adjusted odds ratio of 0.76. Next slide. Using a similar design, this is a multi-study cohort of children enrolled between July of 2021 and September of 2022, and then followed for post-COVID conditions occurring at least 1 month after infection. All of these cases were during the Omicron variant period. In this study, an mRNA COVID-19 vaccination appeared to be protective against the development of post-COVID conditions among children, with an adjusted odds ratio corresponding to vaccine effectiveness of 34%, 48%, and 47% for at least one post-COVID condition symptom, 2 or more post-COVID condition symptoms, or respiratory specific post-COVID condition symptoms. Next slide. Next slide. So in summary, I want to leave you with a few important take-home messages. First is that post-COVID conditions are common following SARS-CoV-2 infection. These conditions do appear to decrease over time since infection. Further, while thousands of individuals are still impacted by post-COVID conditions, the prevalence and occurrence has decreased since the beginning of the COVID-19 pandemic. These symptoms and conditions are not unique to having had SARS-CoV-2 infection, since our definition of post-COVID conditions encompasses a very broad array of symptoms and conditions. Post-COVID conditions are associated with an increase in healthcare utilization and significant activity limitations that impact daily activities, work, and school. And there is good news in that there is accumulating evidence that COVID-19 vaccination reduces post-COVID conditions, both among children and adults. Next slide. Thank you.
Thank you very much. Next, we'll move on to our last presentation in this section before we take questions. With Dr. Ruth Link-Gillis will present on COVID-19 vaccine effectiveness updates.
Thank you, Dr. Lee. My name is Ruth Link-Gillis, and today I'll be presenting a summary of vaccine effectiveness data available from CDC studies. Next slide. VE updates today will be focused on emergency department and urgent care visits in children and adolescents, and emergency department visits, urgent care visits, hospitalizations, and critical illness in adults. Note that the information included in this presentation is meant to complement results of the GRADE analysis, and in many cases—
Dr. Link-Gillis, we can't hear you yet, but it might be that you haven't started.
We are rearranging to a different microphone.
Thank you, Dr. Warden.
Dr. Lee, can you hear me now?
Yes, we can. Thank you.
Great, thanks. Can you just go back one slide? Okay, so my name is Ruth Gillis, and I'll be presenting a summary of vaccine effectiveness data available from CDC studies. Next slide. VE updates today will be focused on emergency department and urgent care visits in children and adolescents, and emergency department visits, urgent care visits, hospitalizations, and critical illness in adults. Note that the information included in this presentation is meant to complement results of the GRADE analysis, and in many cases includes updates to published studies included in GRADE. Before diving into VE estimates, I wanted to provide a bit of context for interpretation of the results I'll share today. By July and August of 2020, just before the bivalent vaccines were introduced, individuals in the US had high rates of infection-induced immunity, well above 50% for age groups, except those 65 and up, which was just below. Hang on one second. Is this better for audio?
Yes, much better. Thank you.
Okay, thank you. Can you go to the next slide? Okay, I'm just going to start this slide over. Before diving into VE estimates, I wanted to provide a bit of context for interpretation of the results I'll share today. By July to August of 2022, just before the bivalent vaccines were introduced, individuals in the US had high rates of infection-induced immunity, well above 50% for all age groups except those 65 and up, which was just below 50%. Infection can provide some protection from future infection, and VE findings should therefore be interpreted as the incremental benefit provided by COVID-19 vaccination in a population with a high prevalence of infection-induced immunity. Next slide. I'll start today with updates to VE against emergency department and urgent care visits in young children. More detailed methods are available at the citation shown here. Next slide. The VISION network is a multi-site network based on electronic healthcare records. It uses a test-negative design, and this analysis included immunocompetent children aged 6 months to 4 or 5 years visiting a participating emergency department or urgent care and receiving a NAT test. Cases had COVID-like illness and a positive NAT test, and controls had CLI with a negative NAT. Vaccination is determined via electronic health record and state and city registries. Next slide. This slide shows VE for an original monovalent Moderna primary series in children aged 6 months through 5 years against ED-UC encounters. On the top half of the slide is VE for a single dose administered at least 14 days and a median of 66 days prior. VE was 23% with confidence intervals crossing the null. The bottom half of the slide shows VE of 2 doses of Moderna at least 14 days prior and then split by time since dose, 14 to 59 days and 60 days or more, with median time since dose for each row shown in the second column from the right. Here we see similar patterns to what we've seen previously in older children and adults. VE starts at 46% and wanes, in this case to 24% by a median of 124 days prior. Next slide. This slide has a similar format to the previous slide, now with an original monovalent Pfizer-BioNTech primary series in children aged 6 months through 4 years. The top section again shows a non-significant VE for a single dose. VE of 2 doses, which is an incomplete primary series for Pfizer, was initially 44% but waned to 23% with confidence intervals crossing the null, a median of 111 days after the second dose. The bottom section of the slide shows VE of 3 doses, or a complete primary series for Pfizer, which is similar to that for 2 doses. Note that there were not enough children to precisely estimate VE by time since the 3rd dose. Next slide. Finally, here we have VE for 1 or more bivalent doses of Pfizer and Moderna combined in children aged 6 months through 4 or 5 years, respectively, among children who had completed a primary series of monovalent or bivalent doses. There was not enough data to estimate VE by time since dose, but VE was 61%, a median of 66 days after the bivalent dose. Next slide. 1 dose of original monovalent Moderna or Pfizer-BioNTech vaccines did not provide significant protection in young children. 2 doses of either product and 3 doses of Pfizer-BioNTech provided protection against ED, and hospitalization, though waning was evident, similar to older children and adults. A bivalent dose provided protection, though sample size was limited. Of note, the median interval since receipt of the most recent dose among children who had not completed their primary series was longer than expected based on recommended dosing intervals, indicating that some children are not completing the primary series. Next slide. Moving on now to updates to bivalent VE from 2 platforms, Vision and Ivy. More detailed methods are available at the links on this page. Next slide. I won't repeat the main Vision methods since I just went through those a few slides ago, but the analyses here and on the next few slides are in older children, adolescents, and adults, and include emergency department and urgent care visits, as well as hospitalizations and critical illness. Analyses in the following slides go from September 2022 through August 2023, so include Omicron, BA.4, 5, and XBB predominant periods. Next slide. This slide shows VE of original monovalent and bivalent doses against emergency department and urgent care visits by age group, including older children and adolescents aged 5 to 17, adults aged 18 to 64 years, and adults aged 65 and up. VE is similar across age groups. Next slide. With little protection remaining from monovalent doses shown in orange, which were administered a median of 11 months or more prior to the index, ED, or UC visit. Next slide. VE of a single bivalent booster dose, shown in magenta, administered 7 to 59 days prior was significantly higher, and again similar across age groups with point estimates between 56 and 63%, with overlapping confidence intervals across the age groups. Next slide. Finally, VE of a bivalent booster dose administered 6 to 119 days prior shows some waning compared to the earlier timeframes, with point estimates again similar across age groups. Next slide. Here we have VE of original monovalent and bivalent doses by time since vaccination against hospitalization among immunocompetent adults. For both age groups, residual protection from the original monovalent vaccine administered a median of over 13 months prior, shown in orange, is low. A bivalent dose, shown in magenta, restored some protection, which then waned in both age groups, with potentially more waning in younger adults, although vaccine uptake in younger adults was low and confidence intervals are wide and somewhat difficult to interpret. Next slide. This slide shows absolute VE of monovalent and bivalent vaccines against hospitalization on the top and critical illness on the bottom, with critical illness defined as admission to the ICU or COVID-19 associated death. Estimates for bivalent VE for both outcomes are shown by time since vaccination in the same increments as on the previous slide. Next slide. Sorry, go back one. As you can see, VE of the monovalent dose, shown here in orange with a median of over 13 months from vaccination, is relatively low. Initially, VE of a bivalent dose, shown in magenta, is high. However, waning is evident against hospitalization on the top. Note that the different pattern against the most critical illness is shown on the bottom. Although VE drops somewhat, it appears more durable at 52%, a median of almost 5 months after the last dose. Next slide. Finally, from Vision, this slide shows VE broken down by immunocompromised status. Individuals without immunocompromise are shown on the top, and individuals with immunocompromise are shown on the bottom. VE point estimates are generally lower for those with immunocompromising conditions compared to persons without immunocompromising conditions. The waning pattern is a little less clear in those with immunocompromising conditions, though VE appears lower in the 120 to 179 day group compared to the 7 to 59 day group, though confidence intervals do overlap. The patterns of waning may be less clear in immunocompromised individuals because of heterogeneity in immune response among those with immunocompromising conditions, or because of limited statistical power to detect differences by time. There were not enough cases to estimate VE specifically for different types of immunocompromising conditions, though VE has been shown to vary based on type of condition previously. Next slide. Next slide. Thank you. Moving on now to the Ivy Network, a multi-site VE platform that uses a prospective case control design. For this analysis, participants were from 25 hospitals in 20 states with hospitalization between September 8th, 2022 and May 29th, 2023. Participants are adults hospitalized with COVID-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test, and controls are negative for SARS-CoV-2 and influenza by NAT. Vaccination history is ascertained through EMRs, state and local vaccine registries, and self-report, and specimens are collected for central testing and sequencing. The analyses were completed for hospitalizations here from September 2022 through May 2023. Next slide. Here we see monovalent and bivalent VE against hospitalization in immunocompetent adults by time since last bivalent dose. As with vision, VE of a monovalent dose received a median of 412 days prior to hospitalization, shown here in orange, was low. IV data show the same pattern as vision data, with the bivalent VE against hospitalization shown in magenta, decreasing with time since vaccination for both younger and older adults, though note that the confidence interval for 90 to 179 days is quite wide in both groups. Next slide. Finally, from IV, this shows VE broken down by immunocompromised status. We see the same pattern of waning among immunocompetent individuals as previously, with a less clear pattern among those with immunocompromise, though note the wide confidence intervals for those with immunocompromise who were vaccinated 90 to 179 days earlier. Next slide. So in summary, current data from CDC vaccine effectiveness platforms demonstrate that bivalent boosters provided additional protection compared to individuals with distant monovalent doses. Waning of bivalent VE against hospitalization and EDUC visits was evident, though there was more sustained protection against critical illness. It's difficult, however, to separate impact of time since vaccination from emergence of new variants. Next, go back. VE patterns include waning, including waning appear similar across age groups, though low uptake of bivalent doses in younger age groups prevented assessment of waning beyond 4 months from the bivalent dose. Persons with immunocompromise may have reduced protection from COVID-19 vaccination compared with persons without immunocompromise. Historically, COVID-19 VE has been lower and waned more quickly for adults with immunocompromise compared to those without. Trends in bivalent VE, however, were less clear and additional data are needed. Finally, as I mentioned at the beginning of the presentation, VE findings should be interpreted as the incremental benefit provided by COVID-19 vaccine in a population with high prevalence of infection-induced immunity. Next slide. This concludes the presentation, and I want to thank the numerous individuals and teams from both CDC and at the platform study sites for their countless hours ensuring high-quality data and analyses are available to ACIP. Thank you.
Thank you very much. And this set of presentation is now open for questions. Dr. Paling.
First, I want to thank each of the speakers for very clear and helpful presentations on what is transpiring now. My first question is to Dr. Havers. In your presentation about the epidemiology and of COVID vaccine hospitalizations, and do you have data on race and ethnicity? Thank you.
We do have data on race and ethnicity. I think if you go to backup slide number 22, I can show that. I think also Dr. Wallace is going to be presenting some data on race and ethnicity in the evidence to recommendation slides. So what I will say is that we have been tracking health disparities throughout the COVID pandemic, and generally speaking, they still remain. But they have perhaps a little bit less than earlier in the pandemic. What the slides up here show the 3-week moving average rate by race and ethnicity from January through August 2023. And then sometimes weekly, and this is the weekly rates with, as you can see, non-Hispanic Black persons, the rates are in blue. American Indian and Alaska Native are shown in yellow, and they currently have the highest cumulative rates, although I will note that the number of American Indian and Alaska Native population within the COVIDNet catchment area is relatively small. If you look at the COVIDNet cumulative rates from the last season, from October 22 to 2023, You can see on the right that rates remain highest in American Indian, Alaska Native populations and non-Hispanic Black populations. We have seen over the last year the gap between Hispanic and non-Hispanic white populations has narrowed a little bit, which is shown in the purple and the black lines there. So we do have data on that. It's also published weekly on our COVIDNet dashboard, so it's publicly available, but I can answer also other specific questions about that.
Thank you. While we're waiting to see if any additional questions arise, I just really quickly, do you have a sense of the vaccination rates as well and whether or not there are disparities in vaccination rates?
I am not the best person to answer that. I think I'm going to defer to Dr. Wallace, who can answer questions on that.
Dr. Wallace, we can come back to that later when you present.
Okay, great. Yes, that's in my presentation.
Thank you. Dr. Sanchez.
Hi, thank you. And again, thank you for the clear presentations. I was wondering, you present, or I guess in one of the presentations, I think it was Dr. Havers, yes, who presented data on high rates of hospitalization among infants less than 6 months. And do you have any data on maternal vaccination in that age group?
We are collecting data at that time. Right now, we don't have any data specifically on those infants who are hospitalized, but that is something that we're looking into, and data collection on maternal vaccination of hospitalized infants is ongoing at the moment. But I apologize, I don't have that available today.
Dr. Paling?
Okay, thank you. I wanted to ask a similar question to Dr. Seda on long COVID. Do we have any differences in long COVID by race and ethnicity? Thank you.
Yes, thank you. That is a good question. I don't have any of that data to present today. We do know that people, because there's been disproportionate impact of COVID-19 by race, ethnicity, and for severity of infection, we would expect that to translate into increased risk for long COVID.
Thank you. Dr. Daly?
Yes, this is a question for Dr. Thornburg. Dr. Thornburg, you mentioned that certain amino acid-based substitutions in the spike might confer survival advantage. And so that made me wonder, to what extent, if any, does vaccination drive virus evolution? Thanks.
Dr. Thornburg, I can see you're unmuted, but we can't hear you yet.
Okay, sorry about that. Was triple muted. So vaccination and infection generate, population immunity, and that population immunity can create bottlenecks for the virus. And so, everybody. How do I say this? Everybody generates a very complex, repertoire of monoclonal antibodies. So you have this, hundreds, thousands of different individual antibodies, and everybody has a unique set of antibodies. And it's hard to quantify just how much vaccination drives that very complex repertoire, infection, or a combination thereof. But population immunity in general can absolutely create bottlenecks for a virus. So if 99% of the population has neutralizing antibodies against, a residue 456, then the virus might, can't infect 99% of the population. Therefore, it has to take hold in or change that one residue if it's able to change that one residue. So just in general, antibody repertoires can create bottlenecks for a virus, and a virus that is able to evolve can find ways around that. But it's hard to quantify vaccination versus infection, especially in the face of durability, where just how much antibody any population has at one given time is difficult to quantify.
Thank you. Dr. Brooks?
Yes, thank you. First of all, excellent presentations. My question, I have one question, one comment for Dr. Seda. First, I really appreciate the data on the effect of vaccination and potential reduction of getting long COVID. I've often felt that a major concern is long COVID, which we will be seeing, years after you have the actual infection, or at least a year. So that's significant, and it's excellent data. And the question I had is, there was a slide that showed that 16% have ongoing symptoms after 12 months. I just wanted to clarify that was 16% of those that had COVID disease, or 16% of those that had what we'll call long COVID.
Yeah, thank you. So that was on slide 7. So that is from a prospective cohort study we had where we enrolled individuals who all had acute COVID-like symptoms at baseline and then tested positive or negative for COVID-19. And that 16% of those who either tested positive or negative continue to have ongoing symptoms at 12 months from the time of testing.
Thank you, because that's that's 1 in 6. That's pretty significant finding. Thank you.
Thank you. Dr. Paling?
Thank you. My question is for Dr. Link Gellis. You presented great data on COVID-19 vaccine effectiveness in both children and adults in prevention of ED, urgent care, and hospitalization. And I wanted to make sure my interpretation is correct. And what I understood is that the vast majority of persons of all ages have had COVID infection, but having an updated COVID vaccine provides additional protection in preventing ED, urgent care, and hospitalizations and severe illness for the older adults, regardless if you're immunocompromised or not. Is that a correct interpretation? Thank you.
Yes, I believe that's a correct interpretation. I mean, generally, I would say because the bivalent and original monovalent vaccines were not authorized at the same time in the US, we can't do sort of a head-to-head comparison of the two. But what we did see was that original monovalent protection had waned quite a bit across age groups and across immunocompromised status. And so the median time since dose for people that did not get a bivalent dose is more than a year for most age groups at this point, so quite a bit out. And so what we saw was that the bivalent booster restored protection that had been lost by the monovalent waning. And then, of course, we do see some waning for the bivalent booster, but we see much more durable protection, both for monovalent and bivalent doses amongst the most critical illness outcomes, so ICU or mechanical ventilation or death.
Dr. Long?
Yes, it's a question for Dr. Havers about the epidemiology of COVID disease and hospitalizations by age. And a special question is about the observation of very high incidence in those under 6 months and under 23 months. And the question is, I believe you referred to it all as COVID. And I assume that I think of COVID as COVID lung disease, as is characteristic in adults and older and obese teenagers. I assume this was not lung disease, but these were hospitalizations mainly for something else like fever or sick, don't know why, or suspicion of or occurrence of MIS-C. Is that correct? Do you have any ballpark numbers or percents of those young children admitted to the hospital with COVID, of what the clinical syndrome was?
Yeah, no, thank you for that question. I hope you can hear me now. We do have data on that. We collect symptoms on all of our, when we do the medical chart review. I would say that the vast majority of children under 5 presented with respiratory symptoms who were admitted with a positive SARS-CoV-2 test. And I will say that the data that I think that most children are having respiratory symptoms. Some of them are being admitted with fever and other things. I don't have a breakdown of symptoms on the slides here, but I'm happy to provide that after. We do collect those data. I would say, generally speaking, respiratory symptoms such as cough, fever, shortness of breath, and then also symptoms like bronchiolitis in younger children are fairly common, but I don't have a breakdown on these slides here. But I think that most of the children that we're talking about here today, including among young infants, do have respiratory symptoms.
And do you believe that of the deaths among children, that the vast majority had COVID-like lung disease rather than the other syndromes that children usually have, with younger children have with coronavirus infection?
I haven't looked specifically at the symptoms among the children that died within COVIDnet in the COVIDnet catchment area, but that's something that we can look into and potentially provide at a later date. I think we have looked at this at other times, like earlier in the pandemic, and we were seeing that a significant proportion of them had respiratory symptoms, but I don't have that data on hand for those specifically who had in-hospital death.
Thank you, Dr. Lair.
Thank you. Could we go to Dr. Sada's slides, please? On slide 4, there's a number of 9% in the middle age groups for the prevalence of symptoms. And then on slide 7, 3 slides further out, it says that this decreases, but that 16% of people still had symptoms at 12 months. I'm just trying to reconcile those two things. Did it go up from 9% down? Because I just want to get a sense of, is it more close to 10%, more close to a quarter of people have symptoms?
Yeah,
Thank you.
it's a good question. It's one of the challenges we have with studying post-COVID conditions. There are multiple approaches to studying this question, and multiple studies will give you slightly different answers. So what is presented in slide 4 is from our National Health Interview Survey. So this is among all U.S. adults as the denominator, and then the numerator for these estimates is report of, for the 9% ever experiencing long COVID, so that's symptoms lasting 3 months or longer. And then that 4.7% in the same 30 to 49-year age group is for those currently reporting long COVID. And then on slide, that next slide that you were referring to on slide, there we go, on slide 7, the 16% was in a prospective cohort study that we had, so that was not representative of the US population. It was among 6,000 individuals who either tested positive or negative for COVID-19 who had acute COVID-19-like symptoms. So it's a different population. The main point here is just that a significant portion of them continued to experience ongoing symptoms at 12 months.
So I'm sorry to ask, but I get asked by patients, if you get COVID, what is your chance of having long COVID at, let's say, 6 months? Are we talking about 1 in 10, 1 in 4? Do you have any sense of that?
I will give you the answer of I think it depends on a number of other factors, right? So all the different things that we have in slide 8 that are corresponding to your likelihood of developing long COVID. So based on your age, severity of the acute COVID-19 illness, whether you have any underlying conditions, and whether or not you've been vaccinated would be some of those factors that would play into that. We don't necessarily have that risk calculation for at the individual patient level on the likelihood of developing long COVID.
Thank you.
Thank you. I'm just going to wrap up this part of the session. I'm just going to acknowledge we're also very far behind, but I wanted to make a few comments for the team to consider. One is that I know that my colleagues and I are very appreciative that we're still collecting epidemiology information as well as, viral variant information, in part because we recognize that COVID is a dynamic infection that's going to change over time, and being able to continue to monitor the ongoing benefit risk balance is going to be very important for this committee and for the public. So again, really appreciate the ongoing infrastructure support for the systems that are able to collect this information. I do think, we did hear a call or a request for continued visibility on disparities, and making sure that we are keeping health equities at the center of many of our activities. So we'll just request that going forward. We continue to include that, be inclusive of that information in these presentations. The second thing I did want to just highlight is that while there were no high-risk conditions that were needed for hospitalization, so it's surprisingly a large number of children, particularly young children, didn't have any high-risk conditions. I do think additional clarity around some of the neurologic conditions, because that's a very broad term, it would be really helpful, particularly children versus adults, in just understanding or unpacking that further, as well as Dr. Long mentioned, just having more information, and particularly in children, around some of the information around in-hospital deaths. And then the final thing I just, wanted to highlight and recognize is that this is the first time I can remember that we're talking about a respiratory viral vaccine that can potentially prevent both acute and chronic illness. And so this is different than how I usually think about it. But thank you for continuing to capture information on long COVID. I think it's really important for our patients and families and the populations to have this information available. And again, a plea for just being able to communicate per Dr. Lair's request, how we can support our families in their decision-making for their kids and for themselves. And with that, I'm going to actually move us along to the economic analysis of COVID-19 vaccines by Dr. Lisa Prosser.
Great, thank you, Dr. Lee. Good morning, everyone. I'm Lisa Prosser, and I'll be reviewing initial results of the economic analysis of an mRNA booster to prevent COVID-19 illness in adults. Next slide, please. I'd like to start by acknowledging our research team, which includes collaborators from CDC and the University of Michigan, who have worked countless hours to contribute to this modeling analysis. Next slide, please. We do not have any conflicts to report. Next slide. The objectives of this study were to first estimate the annual disease burden and healthcare utilization associated with COVID-19 illness and COVID-19 booster vaccination, including cases of symptomatic illness, hospitalizations, deaths, adverse events, costs, and quality-adjusted life years. And second, to project the cost effectiveness of an updated mRNA booster against COVID-19 associated illness in persons ages 18 and older. Next slide. The intervention strategies included in the analysis were vaccination against COVID-19 illness with an updated generic mRNA booster, compared with no updated mRNA booster, that is vaccination against COVID-19 illness of primary series only or primary series plus current booster. The target population included all US adults stratified by age into the following age groups: 18 to 49 years, 50 to 64 years, and 65 and older. Pediatric and adolescent age groups are excluded from the current analysis. There were insufficient data to incorporate these age groups into this first phase analysis, and these will be incorporated into later analyses as more data become available. Time horizon for the analysis is 1 year, with costs and qualities lost due to long-term sequelae and deaths beyond 1 year accounted for. The analysis uses a societal perspective with a costing year of 2023 and a discount rate of 3%. Next slide. We use simulation modeling to project costs and health outcomes for each age group. This slide shows a simplified schematic of the simulation model. In the model, an individual has some probability of remaining disease-free or experiencing COVID-19 illness. If they experience COVID-19 illness, they can have an episode of non-hospitalized COVID-19 illness or become hospitalized due to COVID-19. Symptomatic illness can also incur an outpatient or ED visit. If hospitalized, the severity of illness can require ICU care or ventilator assistance. All individuals who experience COVID-19 illness are at risk for long COVID. Hospitalized patients also have probabilities of long-term permanent sequelae or dying from COVID-19. As simulated individuals travel through the model, they accumulate costs and loss in quality of life associated with each health state. Also included in the model are adverse events associated with vaccination, including systemic reactions, anaphylaxis, and myocarditis. These events are also associated with costs and loss of quality of life, depending on the severity of the adverse event. Each probability, cost, and quality adjustment is represented by a most likely value and a range of plausible parameter values. Identical cohorts are run through the two submodels, one in which all individuals in the cohort receive a booster dose and one in which they do not. Next slide, please. The analysis is designed to project disaggregated health and economic outcomes stratified by intervention strategy and by age subgroups, including cases, hospitalizations, deaths, costs, and quality adjusted life years. Incremental cost effectiveness ratios in dollars per quality are calculated comparing updated mRNA booster to no booster. This metric measures the additional investment in vaccination or cost savings associated with a change in health benefits.
There you go. Hello. There you go.
Hello, can you hear me?
Our colleagues from Pfizer, could you please mute? Thank you.
Are you able to hear me? Okay, great.
Yes.
So this metric measures the additional investment in vaccination or cost savings associated with a change in health benefits and accounts for offsets due to averted illness. We also conducted a set of uncertainty analyses, one-way sensitivity and scenario analyses to explore the robustness of the results to changes in input parameters. It's important to note that this presentation reports preliminary results only from the first phase of an ongoing analysis. Next slide, please. In the next slides, I'll briefly present the key inputs into the model. Most parameters rely on unpublished data, which best reflects the current evidence base for COVID-19 illness and the effectiveness of an mRNA booster. Next slide, please. The probability of symptomatic infection is based on the last 6 months of available data from the HEROES Recover cohort, shown on the left-hand side of the slide, assuming that rates from the most recent 6-month period available would serve as a reasonable proxy for predicting future rates of symptomatic illness. These are translated into annual probabilities stratified by age group and shown in the table on the right. Next slide, please. This slide shows the same probabilities of symptomatic infection from the previous slide, along with associated ranges. Upper and lower bounds were derived from the months with lowest and highest rates of symptomatic infection in the last 6 months and varied more widely in scenario analyses. Next slide, please. This slide shows the probability of an outpatient visit due to COVID-19 derived from Meredith market scan data. Again, the last 6 months of data are used. Note this is an earlier time frame than the COVIDNet data or the previous data that we saw from the HEROES Recover cohort. Next slide, please. The probability of an outpatient or D visit from the market scan data are combined with the probability of symptomatic infection from the HEROES Recover data using a common time period to derive a conditional probability of outpatient visit or ED visit given symptomatic illness. Both probabilities increase with age and associated ranges are listed in the table. Next slide, please. The annual probability of hospitalization is also derived using the last 6 months of data, this time from the COVIDNet data set. Probabilities and associated ranges are shown on the table on the right. Probabilities increase with age. The lower panel simply translates these into rates per 100,000 individuals. Next slide, please. The probabilities of requiring ICU care or ventilator assistance are also derived from COVIDNet data and vary with age, as shown here. Next slide. The probability of dying from COVID-19 depends on the severity of illness, increasing both with severity of illness and with age. Again, these parameters are based on unpublished COVIDNet data. Next slide. Parameters relating to long COVID in the model assume a median duration of 5 months of symptoms. The base case probability as shown here is estimated at 7.2% with a range of 5.8 to 9.1%. The evidence base reflecting the discussion that just occurred is even less robust than for other endpoints. And although the risk of long COVID is almost certainly associated with both age and severity of illness, these associations are not yet incorporated into the model and will be updated as more data become available. Next slide. In the next few slides, I'll review the approach used to estimate vaccine effectiveness for an mRNA booster. Vaccination-related adverse events are also accounted for in the model. Next slide. The panel on the left shows data on effectiveness against hospitalization for the bivalent booster from the VISION study by interval days since last dose. Using data available for 180 days, 3 scenarios were used to extend the vaccine effectiveness to 1 year. An optimistic scenario, which assumes the VE observed in the last period remained for the duration of the year, a conservative scenario in which VE waned to 0 beyond 180 days, and a midpoint scenario, which assumed linear waning from 180 days until the end of the year. Next slide. Using the same approach, we derived annual waning function for the bivalent booster using data from the IV study. Next slide. Combining data from the VISION and IV studies, we calculated the area under the curve to estimate annual VE for an mRNA booster as shown in the bottom panel. Next slide. This slide summarizes the AUCs for the conservative and optimistic scenarios for each of the VISION and IV studies. The minimum of the conservative estimates and maximum of the optimistic estimates were selected for the lower and upper bounds for VE, and the base case VE is shown in the bottom row on this table. Again, this is against hospitalization. Next slide, please. A similar approach was used to derive VE for critical illness using VISION and IV data. This is a combined endpoint that includes both ICU care and deaths. This VE is then applied to both of these endpoints in the model. Additional uncertainty analyses are conducted for VE to reflect the uncertainty in the underlying evidence base. Next slide. Data were unavailable to inform VE against symptomatic illness. An assumption was made to apply the same VE for uncomplicated hospitalization to symptomatic illness. And sufficient data were not available to evaluate possible variation by VE by age group. Next slide, please. The probabilities of adverse events were included in the analysis as shown here for systemic reactions, anaphylaxis, and myocarditis. A very small probability of dying due to vaccine-associated anaphylaxis or myocarditis is also included in the model. These parameters are informed by FDA fact sheets, published data, and expert opinion. Next slide. The model also includes direct medical costs and productivity losses associated with lost time from work and other productive activities due to illness or vaccination-related adverse events. Next slide. This table lists the costs associated with testing for non-medically attended symptomatic illness, as well as those for an outpatient visit. It's assumed that testing costs for illnesses incurred associated with an outpatient visit are included in the costs of the outpatient visit. So these are only included separately for the symptomatic illnesses which are not medically attended. Again, the costs of long COVID reflect a median duration of a 5-month episode. Outpatient costs and costs associated with long COVID were estimated using market scan data. Next slide, please. Costs of hospitalization were also
increases as we enter respiratory virus season. Infants and older adults have the highest COVID-19 associated hospitalization rates. Children and adults with no underlying medical conditions still experience severe illness due to COVID-19. We saw in Dr. Seta's presentation earlier that post-COVID conditions are common following SARS-CoV-2 infection, decrease with time since infection, and have decreased since the start of the pandemic. People of racial and ethnic minority groups continue to be disproportionately impacted by COVID-19. High proportions of underlying conditions may put certain groups at increased risk for severe outcomes due to COVID-19. Next. When asked, is COVID-19 disease among persons 6 months and older of public health importance, the majority workgroup opinion was yes. Next. Now we will move to benefits and harms. Next. The available evidence include data from the 3 manufacturers, including clinical trial data from Moderna and preclinical data from Novavax and Pfizer. We have a great assessment of the benefits and harms of an updated COVID-19 vaccine. We also have data from post-authorization safety and effectiveness monitoring, which were described in presentations earlier today by Drs. Klein and Link-Gellis, detailing the intense and comprehensive safety and effectiveness monitoring of COVID-19 vaccines. As a reminder, millions of people in the United States have received COVID-19 vaccines under the most intense safety monitoring in U.S. history. We also have additional considerations, including a benefit risk assessment and modeling data. Next. Starting with the available data from COVID-19 vaccine manufacturers, Moderna provided clinical trial data from 101 patients randomized to receive a monovalent XBB.1.5 containing dose or a bivalent BA.4/5 and XBB.1.5 containing dose. Patients that received the monovalent XBB.1.5 containing dose demonstrated an increase in neutralizing antibodies with similar levels of neutralization across several XBB subvariants. Reported reactogenicity was similar to or lower than that reported from previous doses. Novavax provided preclinical data demonstrating that macaques boosted with XBB.1.5 showed an increased neutralizing response across several XBB pseudoviruses. And Pfizer provided preclinical data demonstrating that mice boosted with XBB.1.5 showed an increased neutralizing response across several XBB pseudoviruses. Next. The GRADE approach was applied to assess the type and quality of evidence for the anticipated benefits and harms of an updated COVID-19 vaccine. The PICO question and inclusion-exclusion criteria were intentionally narrow to best capture evidence most applicable to what can be anticipated from this year's vaccine dose in the U.S., including limiting evidence to U.S. studies of an updated vaccine formulation, in other words, the bivalent mRNA vaccines. 2 separate PICO questions were evaluated based on dosing cutoffs. The narrow criteria reduced the number of studies available in the body of evidence. However, this GRADE assessment builds upon a large body of evidence from the original monovalent vaccines. Next. For adolescents and adults, the components of the PICO question are shown on this slide. The population under consideration is persons ages 12 years and older. The intervention is 1 dose of an updated mRNA vaccine. The comparison is no updated vaccine. The workgroup identified the 6 outcomes listed here as the most important for the policy question. Next. And here's the PICO question for our pediatric age group, ages 6 months to 11 years. The workgroup identified the 7 outcomes listed here, which include all of the adult outcomes with the addition of MISC. Next. The importance and data sources available for evaluation of these outcomes are summarized here. Next. To identify relevant vaccine effectiveness studies, we used ongoing publicly available systematic review conducted by the International Vaccine Access Center, or IVAC, and the World Health Organization. We examined studies identified through June 29, 2023. More recent VE data were presented in Dr. Link-Ellis's presentation. For observational data on vaccine safety, in consultation with the Immunization Safety Office, we included data from safety surveillance systems that have been presented to ACIP. To identify relevant randomized control trials, we relied on clinicaltrial.gov as the source. We included phase 1, 2, or 3 trials of COVID-19 vaccines, and we sought out additional resources, including obtaining unpublished data from the vaccine manufacturers. Next. A total of 6 observational studies were identified that met our inclusion criteria and addressed 1 or more of the PICO outcomes. We conducted a risk of bias assessment using the Newcastle-Ottawa scale, which assigns up to 9 points based on specific criteria related to selection, comparability, and assessment of outcome or ascertainment of exposure. Studies with a Newcastle-Ottawa scores less than 7 were considered to have serious study limitations. Next. For each outcome, we assessed the body of evidence for suitability of pooling. If multiple studies were conducted in the same population, the most representative study was selected. Meta-analyses were conducted using appropriate estimates from the remaining studies. Initial estimates were evaluated for heterogeneity. The pooled estimates were developed to summarize the estimates across several studies succinctly for GRADE and describe the best available real-world data for the policy question at this time. Next. For the important outcome of medically attended COVID-19, 2 studies were identified in the systematic review. This forest plot shows the VE estimate for each study. The pooled VE estimate from these studies was 53.1%. Next. For the outcome of medically attended COVID-19, we evaluated 2 observational studies. There was a risk ratio of 0.47. There were no serious concerns in the certainty assessment. Since evidence type starts at low for observational studies, despite there being no serious concerns, the final certainty was low. Next. For the outcome of hospitalization due to COVID-19, 4 studies containing 8 VE estimates appropriate for pooling were identified in the systematic review. This forest plot shows the VE estimates for each study. The top 2 estimates were from cohort studies. The following estimates are from case control studies at 7 to 59, 60 to 119, and 120 to 179 days following a bivalent dose and demonstrate waning of the vaccine effectiveness over time. A more comprehensive look at the impact of waning was given in Dr. Link-Ellis's presentation. The pooled estimate across studies and time points was 47.8%. Next slide. For the GRADE assessment for the outcome of hospitalization due to COVID-19, we evaluated 4 observational studies with a pooled risk ratio of 0.52. There were no serious concerns in the certainty assessment. The final certainty assessment based on the observational data was low. Next. This forest plot shows the 2 VE estimates from observational studies for the outcome of death due to COVID-19. The pooled VE estimate from these studies was 60.5%. Next. For the outcome of death due to COVID-19, the pooled risk ratio was 0.39. There was serious concern for inconsistency as magnitude of effect and 95% confidence intervals from the two studies and the body of evidence varied widely, possibly reflecting differences in study methods. The final evidence type was very low. Next. For the outcome of post-COVID conditions, there were no studies that met the IVAC inclusion criteria. The common reasons for exclusion are listed on the slide. Although data were not formally included in GRADE, Dr. Seda gave a comprehensive review of what we know in her earlier presentation on post-COVID conditions. Next slide. For the critical outcome of serious adverse events, we examined two rare specific events, myocarditis and anaphylaxis, that have been associated with vaccination. For myocarditis, we evaluated an observational safety study from the Vaccine Safety Data Link, or VSD, which evaluated chart-reviewed cases of myocarditis occurring among adolescents and adults ages 12 to 39 years following a monovalent booster dose and bivalent booster doses based on events occurring in a 7-day interval after vaccination versus a comparison interval. Here we can see that rates of myocarditis and pericarditis varied by gender, age, vaccine product, and dose number. The highest rates were observed among younger males following the first booster dose of the original monovalent vaccine. While rates following a bivalent booster dose appear lower, they should be interpreted with caution due to a low number of doses captured in VSD and confidence intervals that overlap with the confidence intervals for risk following the monovalent booster. It's also important to note that myocarditis rates following a monovalent and bivalent boosters are lower than the rates observed following the primary series vaccination. Next slide. Regarding anaphylaxis, we examined data from VSD chart-reviewed cases of anaphylaxis among all vaccinated persons ages 12 years and older. Based on events occurring in a 0 to 1 day risk interval after vaccination, we estimated incidence of confirmed anaphylaxis among adolescents and adults was 4.8 per million doses of Pfizer-BioNTech and 5.1 per million doses of Moderna. There were fewer cases of anaphylaxis post-dose 2 compared with dose 1. Next slide. Two specific rare SAEs have been associated with vaccination through safety surveillance. There were no serious concerns in the certainty assessment. The final evidence type was low certainty. Next. For the important outcome of reactogenicity, we examined grade 3 or 4 local and systemic events following either dose of the original COVID-19 monovalent primary series. This forest plot shows the pooled magnitude of effect for the outcome of grade 3 or 4 reactogenicity. Pooling the data from the randomized controlled trials, we estimated a relative risk for any grade 3 or 4 event after vaccination was 4.83. Next. There was very serious concern for indirectness as the available body of evidence did not include anyone who received an updated dose, was from a prior period of the pandemic, and excluded persons with prior COVID-19 infection, pregnant or breastfeeding women, and persons who are immunocompromised. The final evidence type was low certainty. Next. This table summarizes our current grade assessment for the updated COVID-19 vaccine in adolescents and adults. Next. Turning now to infants and children, we reviewed the observational data sources based on the pre-specified systematic review criteria, and the only study that was captured was one manufacturer's funded preprint among persons ages 6 years and older that studied a single vaccine. However, we can infer the benefit seen in adolescents and adults and downgrade for indirectness. The rationale for this inference is supported by the similarity in VE estimates across adult and pediatric age groups, which was presented by Dr. Link-Ellis. Here we see the pooled vaccine effectiveness findings against EDUC visits, hospitalization, and death that we just discussed in depth among adolescents and adults. The certainty for each of these outcomes in the pediatric population is downgraded for indirectness, which leads to a certainty of very low for all of the outcomes. Next. Turning now to harms in the infants and children. In the same previously mentioned analysis from VSD of myocarditis and pericarditis among children ages 5 to 11 years following a monovalent booster dose, there were 0 cases of myocarditis among roughly 50,000 males and 0 cases among 49,000 females receiving Pfizer. Next. And here we again see the rate of anaphylaxis in persons ages 12 and older, which can be used to infer the rate of anaphylaxis among children. Next. 2 specific rare SAEs have been associated with vaccination through safety surveillance. In the certainty assessment, there was serious concern for indirectness as the body of evidence for myocarditis was limited to children aged 5 to 11 years receiving a monovalent dose during an earlier period of the pandemic, and the body of evidence for anaphylaxis was among a different age group, who again received monovalent doses during an earlier period of the pandemic. The final evidence type was low. Very low certainty, sorry. Next slide. This forest plot shows the magnitude of effect for the outcome of grade 3 or 4 reactogenicity. The top forest plot includes children ages 5 and 6 to 11, and the bottom forest plot includes children ages 6 months to 4 and 5 years. The difference in the magnitude of effect between the two age groups likely reflects the differences in systemic events captured and the inherent challenges in reporting reactogenicity among the youngest children. Therefore, pooled reactogenicity among the older age group was used for grade. Next. Pulling data from the two trials, we estimated a relative risk for any grade 3 or 4 event was 4.69. There were very serious concerns for indirectness as the available body of evidence did not include anyone who received an updated dose and excluded children who were immunocompromised. While children with a history of COVID-19 infection were included in the safety sets, the RCTs were conducted at a time of lower seroprevalence. The final evidence type was low certainty. Next. And here we have the summary of findings and evidence types in infants and children. Next. Regarding Novavax vaccine effectiveness and safety, due to the lower uptake of Novavax COVID-19 vaccines, no post-authorization vaccine effectiveness estimates from the prior COVID-19 vaccine formulation are available. Post-authorization safety data are also limited by the low number of doses administered. Available data from the Vaccine Adverse Event Reporting System, or VAERS, are consistent with those from pre-authorization clinical trials. Most VAERS reports were classified as non-serious. The most commonly reported adverse events included dizziness, fatigue, and headache. No new safety concerns were identified. Next. We conducted a benefit-risk assessment for the updated COVID-19 vaccines. This figure shows estimated COVID-19 hospitalizations that would be prevented over 6 months per million updated mRNA COVID-19 doses among those aged 50 and younger. Those 65 years and older were not included to allow better visualization of the smaller estimates in these younger age groups. The blue bars represent benefits when hospitalization rates are similar to those from the spring, which had the lowest rates. Green represents rates from December 2022, the winter high, and gray are rates from summer 2022, which had the highest rates from the past year. One key takeaway is that the benefits are highly dependent on the hospitalization rates. But even with the lowest rates that we've seen, benefits of COVID-19 vaccination are anticipated in all age groups. For example, among those ages 6 months to 4 years, shown at the top of the figure, we estimate 103 to 476 hospitalizations per million doses would be prevented over a 6-month time period. Anticipated benefits are lowest in the 5 to 11 and 12 to 17-year-olds. Next. We also wanted to consider the potential myocarditis risk following updated COVID-19 vaccines in the age groups for which risk was observed following the primary series. There are limited data to inform the myocarditis risk following an updated mRNA dose. Myocarditis rates following a booster dose in adolescents and young adult males are lower than the rates following primary series, but estimates are limited by fewer number of doses for both the bivalent boosters and the previous monovalent boosters administered in VSD, which limits the precision for this rare outcome. Additionally, myocarditis risk is lower with the longer time between doses. We saw that rates of myocarditis were lower with an extended interval between dose 1 and dose 2 for the primary series. A longer interval between updated doses may also impact the myocarditis rates. Studies have shown that most individuals with pericarditis have fully recovered at follow-up, and in a study done earlier in the pandemic, the risk of adverse cardiac outcomes was notably higher after SARS-CoV-2 infection compared to after mRNA COVID-19 vaccine among young males. Next. On this slide, we are focusing on the adolescents, the group that had the highest risk for myocarditis following primary series and first booster. In addition to the hospitalizations prevented shown earlier, we've calculated that 5 to 19 ICU admissions and 0 to 1 deaths are anticipated to be prevented per million doses over 6 months. For both males and females, these benefits compare with 0 myocarditis cases and over 55,000 bivalent doses administered in VSD for each group. Next. This slide returns to the scenario modeling hub work, which was described earlier. Here we are looking at the cumulative difference in hospitalizations and deaths by vaccine recommendation scenario. If we focus on the red boxes, we see that a universal vaccine recommendation is projected to prevent about 400,000 hospitalizations and 40,000 deaths over the next 2 years, compared with no recommendation, regardless of the level of immune escape. Next. And here we see that compared with only vaccinating those 65 years and older, a universal vaccine recommendation is projected to prevent about 200,000 more hospitalizations and 15,000 more deaths over the next 2 years. Next. Now for the domain equity question. Are the desirable and undesirable anticipated effects demonstrated across all populations equally? Next. There are no evidence to suggest that COVID-19 vaccine effectiveness varies substantially by race or ethnicity. However, differences in vaccine hesitancy and uptake, crowding, access to care, and prior infection could impact vaccine effectiveness, and these factors may also differ by race and ethnicity. There is no evidence to suggest that COVID-19 vaccine safety profiles differ by race and ethnicity, but risk has been shown to differ by age and sex. Risk for myocarditis is highest in adolescent and young adult males. It is important to note that benefits and harms for the U.S. population are best assessed when clinical trial and study populations are optimally representative of the U.S. population. Next. In summary, monovalent XBB containing COVID-19 vaccines increase the immune response against the currently circulating variants. Last year's updated vaccine was effective at preventing medically attended COVID-19, hospitalizations due to COVID-19, and death due to COVID-19. Additionally, as you saw in Dr. Seta's presentation, there is accumulating evidence that COVID-19 vaccination reduces post-COVID conditions among both children and adults. COVID-19 vaccines have a high degree of safety. Rare events of myocarditis and anaphylaxis have been seen in post-authorization studies. It is unlikely that updating the formulation would increase adverse events. COVID-19 vaccine benefits are anticipated in all age groups, but the benefits of COVID-19 vaccines vary by age and incidence of COVID-19 hospitalizations. The benefits outweigh the risks in groups for which risk of myocarditis is highest. Modeling projects more hospitalizations and deaths are averted when updated doses are universally recommended compared to no recommendation or recommendation only for persons 65 years and older. Next slide. When the work group was asked how substantial are the desirable anticipated effects, the majority opinion was that the desirable anticipated effects were large, while a minority felt that it varies. Next. When asked how substantial are the undesirable anticipated effects, the work group felt that they are minimal or small. Next. Finally, when asked do the desirable effects outweigh the undesirable effects, the work group felt the balance favors the intervention, which is the 2023-2024 COVID-19 vaccine. Next. Now we'll move to the values domain. Next, thanks. This slide shows Americans' impression of the coronavirus situation in the U.S. over time. As you can see, the perception of whether things are getting better or worse has fluctuated throughout the pandemic, generally following changes in the infection rate. Over the last year, more Americans have consistently said that the coronavirus situation is getting better rather than worse. As of February, 62% said the situation was getting better, and 30% said it was staying the same, while just 8% said it was worsening. Next. Despite feeling that the COVID-19 situation was getting better, as of August, 30% of the U.S. adults report feeling very or moderately concerned about getting COVID-19. Next. Additionally, people still report concern about serious COVID-19 illness in their family. In March, 50% of people reported being very or somewhat concerned about a family member becoming seriously ill from COVID. Next. For equity, we considered if there is important variability in how patients or populations value the outcome. Next. This slide shows concern about getting COVID-19 by race and ethnicity. As you can see, there are differences in the level of concern by race and ethnicity, with white people having the highest percentage reporting that they are not at all concerned, while Black people have the highest percentage reporting that they are very concerned. Next. When considered by urbanicity, those living in urban areas reported more concern over getting COVID-19 than those in suburban or rural areas. Next. And when considered by income, concern about getting COVID-19 decreased as income increased. Next. In summary, as of February 2023, the majority of Americans felt COVID-19 was getting better. 30% of U.S. adults report that they are very or moderately concerned about getting COVID-19, and half of U.S. adults continue to have concerns about a family member becoming seriously ill from COVID-19. Racial and ethnic minority groups, those living in urban areas, and those with lower incomes are more concerned about getting COVID-19. Next. The majority of the work group felt that the target population feel that the desirable effects are moderate relative to undesirable effects, though a minority felt that it varies. Next. The majority of the work group felt that there was probably important uncertainty or variability in how much people value the main outcome. A minority of the work group felt that there was uncertainty or variability in how much people value the main outcome. Next. Now we'll move to acceptability of the intervention. Next. This slide shows intent to get a new, updated COVID-19 vaccine as of August. 42% of respondents reported that they definitely will or probably will get the COVID-19 vaccine this fall. Next. Based on data from the bivalent vaccine uptake and intent, we see that intent is highly related to receipt of previous COVID-19 vaccine doses. Those that had a past COVID-19 vaccination were more likely to have received a bivalent vaccine dose, while the majority of the unvaccinated reported that they probably or definitely will not get a bivalent vaccine dose. Next. And when we look at the top concerns or issues regarding the bivalent vaccine, among those that reported that they probably or definitely will not get the vaccine, regardless of past vaccination status, the most commonly reported concern was unknown serious side effects. Next. This slide shows reported confidence in vaccine safety for COVID-19 vaccine, influenza vaccine, and other routine vaccines. Confidence in vaccine safety is higher for influenza and other routine adult vaccines than for the COVID-19 vaccine, with only about half of respondents reporting that the COVID-19 vaccine is completely or very safe. Next. This slide shows the percent of individuals that were eligible to receive a vaccine that reported a vaccine recommendation by their healthcare provider. Although a majority report receiving a COVID-19 vaccine recommendation, this number is lower than what is reported for other vaccines. Next. And this provider recommendation seems to matter. On this slide, you see vaccine receipt by healthcare provider recommendation, and we see that those who received a provider recommendation were more likely to receive the recommended vaccine, and this is true across all vaccines. Next. Data from a fall 2022 doc-style survey were analyzed to examine the prevalence of COVID-19 vaccination attitudes and practices among healthcare providers caring for women of reproductive age, and to assess whether providers recommended and offered or administered the COVID-19 vaccines to their pregnant patients. Overall, 82.9% of providers reported recommending COVID-19 vaccination to women of reproductive age, and 54.7% offered or administered the vaccine in their practice. Among healthcare providers who cared for pregnant patients, obstetrician gynecologists were more likely to recommend the COVID-19 vaccine to pregnant patients than were family practitioners or internists. Healthcare providers were more likely to offer or administer COVID-19 vaccination on-site to pregnant patients if they also offered or administered influenza or Tdap vaccines. Next. Now we will consider if the intervention is equally acceptable across all populations. Next. This figure shows COVID-19 vaccine safety confidence by race and ethnicity. We see some variability here, with white non-Hispanic people having the largest percentage at either end of the spectrum, with 23% reporting they feel the vaccine is completely safe and 23% saying they feel it is not at all safe, while other racial and ethnic groups have larger percentages that fall in the middle. Next. When we look at perceptions of COVID-19 vaccine safety by income, we see that those with higher income report higher levels of confidence in the safety of COVID-19 vaccines. Next. There are also differences in confidence by urbanicity, with 30% of people living in rural areas reporting they feel the vaccine is not at all safe. Next. This slide shows fall vaccination intent by age group. We can see that the vaccine intent increases by age, with those ages 65 years and older being the most likely to report intent to vaccinate. This trend is also seen with other vaccines such as flu. Next. And this intent to get a fall COVID-19 vaccine mirrors the uptake we saw with the bivalent doses, with older adults having a much higher coverage than younger adults and children. Next. Intent to get a new, updated COVID-19 vaccine varies some, but not substantially by race and ethnicity. Next. However, there continue to be disparities in receipt of COVID-19 vaccination by race and ethnicity, particularly receipt of a bivalent dose. Next. Like we saw in the overall population, healthcare provider recommendation is important across racial and ethnic groups, with those that receive a provider recommendation being more likely to receive a COVID-19 vaccine. Next. At the June ACIP meeting, we heard data regarding the risk of severe outcomes due to COVID-19 in pregnant people. This figure shows the percent of pregnant people ages 18 to 49 who are up to date with COVID-19 vaccines overall and by race and ethnicity. We can see that the percent that are up to date for all races and ethnicities depicted in yellow is low overall. There are also disparities by race and ethnicity, with Black and Hispanic pregnant people having the lowest vaccine uptake. Next. In summary, vaccine receipt varies by age and race and ethnicity. Fall vaccination intent increases with increasing age. Those ages 65 years and older have the highest percentage of vaccination intent compared to other age groups. Confidence in COVID-19 vaccine safety differs across the population. Compared to other vaccines, COVID-19 vaccines were recommended the least by healthcare providers, but those who received a provider recommendation overall and by race and ethnicity were more likely to receive the recommended vaccine. Encouraging healthcare providers to recommend, offer, and administer COVID-19 vaccines could help reinforce vaccine confidence and increase coverage. Next. When asked if the 2023-2024 COVID-19 vaccine was acceptable to key stakeholders, the majority of the work group felt that it varies, while a minority said yes or probably yes. Next. Now we will move to feasibility. Next. Vaccines with a monovalent XBB.1.5 composition will be the first COVID-19 vaccines to be available directly from the manufacturers as part of the commercial market, rather than through the United States government. While providers will no longer be required to report inventory to vaccines.gov after vaccines transition to being available on the commercial market, they will continue to be encouraged to report voluntarily. The public will continue to be directed to vaccines.gov to find providers offering COVID-19 vaccine. CDC will continue its efforts to make sure that all people have access to COVID-19 medical countermeasures and know where to find product now and in the future. Next. There are several important changes that will make vaccine implementation more feasible. Inclusion of COVID-19 vaccines and vaccines for children will likely result in more pediatricians stocking the vaccine. There will be single-dose vial presentations and smaller minimum order quantities. This directly addresses concerns from healthcare providers, is likely to reduce wastage, eases logistics, and helps with storage capacity limitations. I won't read through them all, but you can see the presentations and order quantities listed here. Finally, preparation is the same or simpler than it was before. Next. Storage and handling will be the same as it is now. Moderna is frozen until expiration in 30 days at refrigerator storage. Novavax is stable at refrigerator storage with a 9-month shelf life, and you must use it within 12 hours of first puncture. Pfizer has ultra-cold storage until expiration and 10 weeks at refrigerator storage. The ultra-cold storage continues to be a challenge, as most provider offices do not have a unit. The dose volume for Pfizer is simplified, now all doses are the same, and Moderna now only has 2 presentations, reducing the chance for errors. Next. There are still barriers to implementation. There are now 3 seasonal vaccines and preventative products, including COVID-19 vaccine, influenza vaccine, and RSV vaccine and preventative products, which means there are more vaccines to manage, limited storage space for more vaccines, and more opportunity for vaccine administration errors. Providers will need to adapt to new cap and label colors, and all 3 manufacturers now have products with blue caps, introducing opportunity for error. Next. Now we will discuss if the intervention is equally feasible to implement across all populations. Next. Now that COVID-19 vaccines have moved to the commercial market, there are disparities in uninsured status that could impact who gets the COVID-19 vaccine. Next. CDC will provide access to COVID-19 vaccines for uninsured individuals once COVID-19 vaccines become commercially available. Uninsured children will be able to receive COVID-19 vaccines through the existing Vaccines for Children program. The VFC program offers vaccines at no cost to eligible children through a national network of participating healthcare providers. Uninsured adults will be able to receive COVID-19 vaccines through a temporary program called the Bridge Access Program for COVID-19 Vaccines and Treatments. This program consists of 2 components. The first component utilizes existing public health infrastructure, including state immunization programs, local health departments, and HRSA-supported health centers to provide COVID-19 vaccines to uninsured adults. The second component will be implemented through contracts with pharmacy chains and will enable them to continue offering free COVID-19 vaccinations to the uninsured through their network or retail locations, as has been done during the COVID-19 public health emergency. Next. CDC's Bridge Access Program for COVID-19 vaccines and COVID-19 vaccine implementation plans are intentionally designed to overcome barriers to access and availability. This includes design for maximized proximity to no-cost COVID-19 vaccines among populations of people who are uninsured or underinsured. CDC and HHS continue to invest in health systems and programs that support vaccine access and outreach in underserved communities, such as HRSA-supported health centers, rural health clinics, and state and local health departments. These networks can be leveraged for access to COVID-19 vaccines as well as other needed medicines. Next. In summary, implementation of the 2023-2024 COVID-19 vaccine will likely reduce wastage, ease logistics, and help with storage capacity limitations and reduce the chance of errors. Nevertheless, there will now be 3 seasonal vaccines and preventative products for respiratory diseases, in which there will be more seasonal vaccines to manage, limited storage space due to these additional vaccines, and more opportunities for vaccine administration errors. Vaccines will continue to be accessible after commercialization with readily available resources for those who are uninsured and reside in underserved communities. Next. The work group felt that yes, the 2023-2024 COVID-19 vaccine was feasible to implement. Next. Now we will move to resource use. Next. You all saw Dr. Prosser's CEA presentation earlier today, but in summary, COVID-19 vaccination is a cost-effective intervention, particularly in persons ages 65 years and older in which the vaccine is cost-saving. Cost-effectiveness estimates in those ages 50 years and older were robust to input changes across plausible ranges. Cost-effectiveness estimates in those 18 to 49 years were sensitive to changes in inputs. If vaccine effectiveness or hospitalization rates are higher than anticipated, the cost-effectiveness estimates would be more favorable. Cost-effectiveness estimates are not yet available for the pediatric population. Next. For equity, we considered if the intervention is a reasonable and efficient allocation of resources across all populations. Next. COVID-19 vaccination is most cost-effective in older adults, in which disease burden is highest compared to younger adults. COVID-19 vaccination is likely more cost-effective in populations with risk factors, such as underlying conditions, which increase their probability of hospitalization due to COVID-19. Additional work is ongoing to evaluate cost-effectiveness in the pediatric populations. Next. When asked if the 2023-2024 COVID-19 vaccine is a reasonable and efficient allocation of resources, the majority opinion was yes, with a minority opinion of probably yes. Next. Now we will move to the summary and workgroup interpretations. Next. The burden of COVID-19 varies by age and underlying condition status, with those ages 65 years and older and those with multiple underlying conditions having the highest risk of severe outcomes due to COVID-19. COVID-19 burden is currently lower than at previous points in the pandemic. However, there are still thousands of hospitalizations and hundreds of deaths each week. Children and adults ages 5 to 49 years had the lowest hospitalization rates overall. However, severe outcomes still occur in this age group, including in people with no underlying medical conditions. Although hospitalization rates are currently low, we have seen rates increase in recent weeks and anticipate further increases as we enter respiratory virus season. The majority of the U.S. population has some level of immunity due to infection, vaccination, or both. Vaccine and infection-induced immunity wane, and new variants have emerged, suggesting that susceptibility remains and may increase over time. Racial and ethnic minority groups have been disproportionately affected by COVID-19. Next. Monovalent XBB containing COVID-19 vaccines increase the immune response against the currently circulating variants. Last year's updated vaccine was effective at preventing medically attended COVID-19, hospitalization due to COVID-19, and death due to COVID-19. COVID-19 vaccines have a high degree of safety. It is unlikely that updating the formulation would increase adverse event rates. Benefits are anticipated in all age groups. Benefits of COVID-19 vaccines vary by age and incidence of COVID-19 hospitalizations. The benefits outweigh the risks in age groups for which there is myocarditis risk. Modeling projects more hospitalizations and deaths averted when updated doses are universally recommended compared to no recommendation or recommended only for persons 65 years and older. Next. The work group considered non-universal policy options, with considerable discussion around the magnitude of benefits in the young, healthy population. As part of these deliberations, the work group requested additional data on severe illness due to COVID-19 in those with and without underlying conditions. There was no group that clearly had no risk of severe illness. Additionally, the vast majority of the U.S. population had an underlying condition that would qualify under a risk-based recommendation. Prevalence of overweight and obesity alone is over 70% in adults. A risk-based recommendation would not allow access to COVID-19 vaccines for all that wanted them. Shared clinical decision-making could create barriers to vaccination and may not effectively target those at highest risk. COVID-19 epidemiology remains uncertain, and non-universal recommendations would need to be quickly revisited if there was an increase in burden. There is currently still substantial COVID-19 disease burden, and simple, stable recommendations may increase vaccine coverage over time. The work group emphasized that COVID-19 recommendations should be reviewed on an ongoing basis as more is learned about COVID-19 seasonality and disease burden in the future. Next. The work group wanted to address COVID-19 vaccine recommendations in children specifically. Burden of severe illness due to COVID-19 is lowest among children ages 5 to 17 years. Despite lower burden relative to other age groups, hundreds of deaths due to COVID-19 occurred in this age group in 2021 and 2022. Half of pediatric COVID-19 deaths were in individuals with no underlying conditions. The number of COVID-19 associated hospitalizations and deaths in this age group are comparable to the burden seen in other vaccine-preventable diseases for which there are universal recommendations. There are potential additional benefits of vaccination, such as prevention of post-COVID conditions and potential for reduced school absenteeism. Risk of myocarditis appears lower than the risk observed following the primary series doses, which may be due to the increased interval between doses. However, certainty is limited by relatively lower sample size of booster recipients in VSD. The future COVID-19 epidemiology remains uncertain, and the low disease burden we are currently seeing may not last. After a robust discussion, the work group was supportive of a universal recommendation at this time. Next. This slide shows a summary of the work groups for each ETR domain. Next. For the balances of consequences, the majority of the work group felt that the desirable consequences probably outweigh the undesirable consequences in most settings, and a minority felt that the desirable consequences clearly outweigh undesirable consequences in most settings. Next. The work group recommended a universal recommendation for the 2023-2024 COVID-19 vaccine. Next. This slide shows the proposed vote language. ACIP recommends 2023-2024 monovalent XBB-containing COVID-19 vaccines as authorized under emergency use authorization or approved by biologics license application in persons 6 months of age and older. Next. Before we move on, I want to present some brief clinical considerations. Next. This slide shows the proposed recommendations for mRNA vaccines. Everyone ages 5 years and older is recommended to receive 1 dose of a 2023-2024 COVID-19 vaccine. Children ages 6 months to 4 years should complete a multi-dose initial series with at least 1 dose of the 2023-2024 COVID-19 vaccine. People who are moderately or severely immunocompromised should complete a 3-dose initial series with at least 1 dose of 2023-2024 COVID-19 vaccine and may receive 1 or more additional 2023-2024 COVID-19 vaccine doses. Bivalent mRNA COVID-19 vaccines are no longer recommended in the United States. Next. There are a few key changes in these recommendations compared to the bivalent recommendations. Previously, everyone ages 6 years and older was recommended for a single bivalent dose. This age has moved to 5 years for the 2023-2024 vaccine. This is because Moderna's age cutoff for the youngest pediatric group shifted from 6 months to 5 years, from 6 months to 5 years to 6 months to 4 years, which now aligns with the Pfizer age groups. This eliminates the complex recommendations that were previously in place for 5-year-olds. There were previously 2 Moderna dosages authorized for 6 months to 5 years. Now the dosages have been streamlined. All Moderna doses in ages 6 months to 11 years are now 25 micrograms, reducing the number of COVID-19 vaccine products in use. Finally, We had an optional second bivalent dose for those ages 65 years and older. We do not have an additional dose recommendation for the 2023-2024 vaccine at this time. We will monitor the epidemiology and vaccine effectiveness to determine if additional doses are needed. Next. In closing, I want to thank this incredible team that is responsible for the work I presented today. Next. Thank you.
Thank you for that very thorough presentation. Let me just confirm. Next, we'll move on to, so just as a reminder, I'm asking my members if they can please hold their questions, but collect them up because I know that was a lot of information. We're going to move on to the overview of COVID-19 vaccine implementation presentation by Dr. Georgina Peacock. And then one more after that, and then we will open it up for discussion and a motion. For Peacock, we can't hear you yet.
Okay, I'm here. Okay, thank you. Thanks, Dr. Lee. So I'm here today to talk to you about COVID-19 vaccination implementation, and I know you heard some of that now, so I'll briefly summarize some of the implementation that we're doing. Next slide. So COVID vaccine fits into CDC's overall fall respiratory virus vaccine program, and you'll see the program goals listed here: to protect Americans from influenza, COVID-19, and RSV, to promote vaccine uptake among those at highest risk, including older adults and those living in longer-term care facilities, people with underlying conditions, people who are pregnant, and children. Communication is really key to this, and communication new and rapidly changing recommendations for all three pathogens is really important. And then implementation to make sure that implementation is equitable, including the Bridge Access Program for COVID-19 vaccines that you'll hear about a little bit later. Next slide. So before I talk about commercialization of COVID-19 vaccines, I want to recognize the tremendous efforts of many, including the multiple groups across sectors represented here today. So taking a moment to reflect that we completed yesterday 1,000 days of COVID vaccine delivery during the pandemic response, which resulted in over 1 billion vaccines distributed and almost 700 million doses administered. It's really a tremendous, tremendous accomplishment for everybody involved. So what will happen now with commercialization of COVID-19 vaccines? What will change is there will be a transition from federal procurement and distribution of all COVID-19 vaccines to a more traditional public and private model. There will be changes in the CDC COVID-19 provider agreements, and then vaccine data will transition to more routine reporting processes, and I'll talk about that in a little bit more in detail. So what won't change is the evidence-based vaccination program that develops recommendations, safety and effectiveness, and then also strengthens vaccine confidence, which you heard a lot about already today. And also CDC's commitment to ensuring access to COVID-19 vaccines at no cost for all Americans. Next slide. So here you'll see a snapshot of COVID-19 vaccine data reporting plans. And I won't go into all of the details, but if you look at some of the things featured here, you'll see that we will continue to get administration data from states. This will happen in an aggregate fashion, receiving monthly data. We also will get more detailed specific data on specific populations, such as pregnant people, people living in skilled nursing units, and be able to look at things like billing and claims data. The Bridge Access Program that you'll hear about more from Dr. Twentyman will also provide additional data for us on those vaccines that are being provided for uninsured adults. And then finally, we will have the information from the National Immunization Surveys, which will provide information on both vaccine coverage and vaccine intent. Next slide. An important part of implementation is having promotion and communication about vaccines. Next slide. So we have And here are some COVID-19 communications that will be part of those pan-respiratory efforts. Next slide. Here is a description of the different communication components and tactics. So we'll both have communications related to healthcare providers and then to consumers overall. So on the healthcare provider side, you'll see that there is different types of media, including social media and press releases, as well as earned media, different types of articles, and work with medical society partner outreach. On the consumer side, there will be similar items, and then there will be a concentrated consumer campaign related to the Bridge program. Next slide. And this just summarizes those different types of outreach activities that we will have. Next slide. So when I move into implementation, the first slide just reminds you, next slide, that you can find out about availability of COVID-19 and flu vaccines on vaccines.gov. And this week we will also be featuring, starting to feature where these vaccines are for the Bridge Access Program. Next slide. So the goal of our program is to ensure no-cost, timely access to COVID-19 vaccines for all. Next slide. So here we describe the availability of COVID vaccine, the federal contracts that have been modified in order to hasten delivery of the 2023-24 COVID-19 vaccines within our public health infrastructure for both children and adults will allow us to have the first doses available within 48 hours of the expected recommendation. There will also be the retail pharmacies that have been contracted to provide doses for uninsured Americans through the Bridge Access Program will also have availability within about that same time period. And we are expecting that commercial insurance commercial product will be expected around that same time frame as well. Next slide. So as we go through ensuring the access for the different populations, you'll see that when we consider access for those who have insurance, next slide, we expect that insurance plans will cover the 2023-24 COVID-19 vaccines immediately. So typically, the Affordable Care Act requires that insurers cover most ACIP recommended vaccines without cost sharing by the next coverage year. COVID-19 vaccines have been recommended on schedule since February 2023. However, in addition to this, for COVID-19 vaccines specifically, in the CARES Act, there was a statement that expedites coverage of COVID-19 vaccines so that they are available immediately upon authorization under EUA or approved under a BLA. And you can see the more detailed information right here. Next slide. So people with Medicare and Medicaid will also have access to COVID-19 vaccines at no cost. COVID-19 vaccines are covered under Medicare Part B without cost sharing, and the Inflation Reduction Act that was passed in August of 2022 eliminates cost sharing for all ACIP recommended vaccines under Medicaid and Medicare Part D equivalent plans, and guarantees that nearly 50 million Medicare beneficiaries and more than 80 million Medicaid beneficiaries will have access to all vaccines recommended by ACIP without cost sharing. Next slide. So as we move into talking about children, the Vaccines for Children program will cover all of those children that don't have private insurance that will pay for the vaccine. Of note, we are approaching our 30th anniversary for the Vaccines for Children program, and you can see some of the accomplishments of this program listed here. Next slide. As a reminder, the VFC program eligibility includes children 0 to 18 years that are either Medicaid eligible, uninsured, American Indian and Alaska Native, or underinsured. Next slide. And so this slide gives you some information about the reach of the Vaccines for Children program, and we do provide vaccinations for approximately 50% of those children in the United States. And COVID vaccine will remain available through Vaccines for Children providers. And so with that, I'm going to turn it now over to Dr. Twentyman to talk to us about the Bridge Access Program. Thanks.
Thank you so much, Dr. Peacock. Next slide, please. Good afternoon, all. My name is Evelyn Twentyman, and I serve as lead for the Bridge Access Program. Today, I'm going to be describing how CDC's Bridge Access Program is designed to protect no-cost access to COVID-19 vaccines for adults, including those who are uninsured and underinsured, and to maximize vaccine proximity, equity, and timely access for all. Next slide, please. Let's start with why this program is needed. As Dr. Peacock explained, this year's updated COVID-19 vaccines will be covered by insurance, and so access for many Americans will not change at all. Additionally, the Vaccines for Children's program will provide these vaccines to uninsured children. However, there are also 25 to 30 million adults without health insurance and additional adults whose insurance will not provide no-cost coverage following commercialization. There is not yet a permanent and comprehensive Vaccines for Adults program to ensure that adults have access to the vaccines recommended for them. And so we are standing up the Bridge Access Program as a temporary solution to maintain access to COVID-19 vaccines specifically in the short term. This program will begin as soon as vaccines have reached participating vaccine providers and will end by December 31st of 2024. Next slide, please. I'll now explain how this program is designed to maximize proximity to these vaccines. Next slide. Our analysis of proximity to COVID-19 vaccines among adults who are uninsured or underinsured found that about 39% of these adults were closer to a public health provider, such as our 317 enrolled providers, state and local health departments, and HRSA-supported health centers, as listed here, while about 61% were closer to a retail pharmacy, such as CVS, Walgreens, or a smaller pharmacy under the eTrue North umbrella. The Bridge Access Program is therefore designed to work through both these public health infrastructure and retail pharmacy components to maximize proximity of adults who are uninsured or underinsured to COVID-19 vaccines. Next slide. The Bridge Access Program COVID-19 vaccines will be available through local healthcare providers, including our 317 enrolled providers and health departments, through HRSA-supported health centers, and through participating retail pharmacies. Next slide, please. Here you'll see a slide containing all national proposed Bridge Access Program site locations. When both public health infrastructure and retail pharmacy components of the Bridge Access Program are included, you'll see that 85% of insured populations live less than 5 miles from a Bridge Access Program site, with particularly high proximity for urban populations. Unfortunately, 5% of uninsured populations are still estimated to be more than 10 miles away from a Bridge Access Program site, and efforts are ongoing to expand the Bridge Access Program footprint. Next slide, please. The retail pharmacies in the Bridge Access Program are using 3 different approaches to maximize access to COVID-19 vaccines. CVS plans to administer doses within both their storefronts and minute clinics. Walgreens plans to administer doses in both their storefronts and at offsite events targeting areas of low access and low uptake. eTrue North is a pharmacy aggregator that subcontracts with smaller pharmacies intended to reach lower access areas without other coverage within the Bridge Access Program. Their discussions with additional potentially participating pharmacies are ongoing. Next slide. I'm now going to speak briefly to how the Bridge Access Program is designed to maximize equity. Next slide, please. The Bridge Access Program is designed to address leading barriers to equitable COVID-19 vaccination, including in accessibility, availability, and confidence. We've already addressed how the Bridge Access Program helps overcome barriers to accessibility and availability. We also want to acknowledge threats to vaccine confidence and explain that to address these barriers, we are working to support and grow vaccine confidence through partnerships with trusted and welcome messengers to communities we serve. Next slide, please. This approach takes lessons learned from the uptake of the 2022-2023 bivalent boosters. We know that in order to reach populations in need of the bivalent booster, we needed to do more than communications campaigns and social media outreach, although these are important. We also needed to work with trusted messengers who were both believed in and welcome by the people that we were trying to reach and could pair messaging with access to COVID-19 vaccines. Next slide. To this end, our community-based partnerships are key. The Bridge Access Program is supporting and working with numerous community-based organizations to undertake multiple activities to reduce barriers to vaccination and improve uptake, including hosting community outreach events, working within their communities as trusted and welcome messengers, partnering with providers to hold special vaccine clinics to provide greater access to vaccination, and to develop additional educational materials to promote COVID-19 vaccination within the Bridge Access Program. Next slide. Now I'm going to briefly turn back to depict the nature of the Bridge Access Program as a temporary solution to an important problem. Let's start on the left. With the creation of VFC about 30 years ago, the U.S. established a comprehensive pediatric immunization program which guaranteed universal access to all ACIP recommended childhood vaccinations to all children regardless of income or insurance status. This program has leveraged resources available under Section 317 of the Public Health Service Act to build and maintain the public health infrastructure necessary to implement quality immunization services nationwide while using resources made available through VFC to guarantee access for the most vulnerable children. In contrast, the infrastructure necessary to ensure availability and access to recommended vaccinations for adults has not yet been well resourced, leaving substantial proportions of the U.S. population, adult population that is, unable to afford these basic life-saving preventive measures. The COVID-19 pandemic proved a stark illustration of why a comprehensive immunization program that supports the entire lifespan is essential to national emergency preparedness. This Bridge Access Program for COVID-19 vaccines is a temporary and limited fix for a problem that can be permanently addressed by enactment of the Vaccines for Adults program proposal, which has been included in the President's FY24 budget. Coupled with Section 317 infrastructure resources, VFA could fill remaining gaps in adult immunization access and do for adults what VFC has done for children. Next slide, please. Before we close today, we want to leave you with resources that will be available for our partners, including several for people within the general public who would like to find vaccination through the Bridge Access Program or help others to do so. Please visit CDC's Bridge Access website for more information. Visit vaccines.gov later this week to find a Bridge Access Program site near you and call 1-800-CDC-INFO with any questions. Next slide, please. Thanks so much, everyone. We want to particularly acknowledge the numerous public health practitioners and leaders across the Immunization Services Division, NCIRD, our interagency partners, and leadership and staff of state and local health public health programs on which our success in vaccination always depends. Thanks so much, everyone.
Thank you so much to all of our presenters. That was an incredible amount of information, a lot to process. And I'd like to open up this set of presentations for questions. As we're taking questions, I will also ask our colleagues at CDC to start to prepare to put up some vote language slides so that we can get a motion on the table.
Dr. Lee, we're having a technical challenge and cannot hear you in the room.
Oh, can others hear me? Is it just the CDC room?
I can hear you.
Okay.
I hear you.
Hold on. Well, I don't know if this is going to be a temporary or a permanent issue, but I do believe we're still recording. So let me just ask that if my colleagues have specific questions, since the room can't hear us, that maybe if you put your hand down and then raise it again, I will call on you and we can confirm the room is ready for questions. So Dr. Freihofer, I see your hand is up.
Yes, Sandra Freihofer, American Medical Association, speaking as a practicing internal medicine physician, and I'm not sure this is the exact time to ask this. But I'm seeing a lot of new infections in my practice consistent with waning protection. In fact, over the last couple of weeks, I've called in more Paxlovid than I have for the past 6 months. And so access to this updated vaccine is so timely and welcomed. And we heard today from the manufacturers about the studies showing cross-protective neutralizing antibodies against these emerging variants. But what do I tell these patients that have been recently infected and now recovered? When can they get the vaccine? Is there a recommended wait time between infection and getting vaccinated? I know in the past, CDC said to wait 3 months after infection, but does that still hold? And like I said, I don't know if this is the right time, but I certainly wanted to get this question in today because I can't wait to get this vaccine out to patients if it is approved by our ACIP today.
Hey, thanks for that question. Can everyone hear me okay?
Oh, we can hear you now.
Okay, wonderful. So you have the option to wait for 3 months, but it is not a requirement. So I think, as soon as they're feeling better, they can get the vaccine if they want it, but they can also choose to wait.
Thank you. I'm going to go back to Dr. Peeling.
All right, so first of all, I want to say a special thank you to Dr. Wallace, Dr. Peacock, and Dr. Twentyman for their great presentations and all the work that's going on to ensure access, equitable access across the country. I've got 2 questions, or a comment for Dr. Wallace and then a question. And in the presentation, it appeared that only about 20% of persons who were pregnant had received an updated COVID vaccine. And I thought that was really important because we saw that the children less than 6 months of age have hospitalization rates with COVID similar to that of adults 65 to 74 years of age. And the best protection that we can give the children is the COVID vaccine. In addition, it helps the moms in reducing prematurity. I wanted to confirm that data is still accurate.
Yes, that is accurate. I think we saw back in the June meeting that vaccination of pregnant mothers showed benefit to their infants.
Okay, and so this is a huge opportunity. And then my question is on clinical considerations. We talked about the complexity of the vials for pediatric offices. So many of them are now just using either Moderna or Pfizer. And so is there going to be a recommendation for offices where a child has received 1 dose of the opposite of what they carry? And how do they complete that dose now? Thank you.
Thank you. The authorization for the youngest kids, the 6 months to 4 years, is still a homologous authorization to complete that initial series. I think if you have that available to you, that's what would be recommended.
Thank you. We're going to go to Dr. Talbot.
This is a very brief comment. Those were fabulous presentations, which would not be necessary if we had vaccines for adults. So I'm just going to put my plug in for vaccine for adults. Thank you.
Thank you, Dr. Talbot. Dr. Sanchez.
Thank you. And, the presentations were really, were excellent. And thank you, Dr. Freihofer, for bringing up the dosing, which I think that, so I'm not sure how much booster somebody needs if they recently were infected with a recent COVID strain. But and I guess, and maybe this should be later, personally, I'm not sure that I'm for a universal recommendation. I certainly think that 65 and over should because of the data presented, and certainly other high-risk groups should. But I think the rest would be made, and I'm glad to discuss it further when when we get to vote. But I'm not yet convinced of a universal recommendation. Thank you.
Okay. Ms. Bata, why don't you go ahead?
Sorry, I've got a wild mouse. Do we know, what can we anticipate in terms of vaccine availability, how many doses are we going to have? And maybe it's not relevant, but I'm curious.
We're not hearing any response from the room. I don't.
Hi,
Oh,
sorry,
there
we were waiting for the microphone. We don't expect to be supply constrained.
Do we have any idea of how many doses are in production for the season across at least the Pfizer and Moderna, since those are recently authorized? And maybe we can ask our
Maybe
Pfizer and Moderna.
the vaccine partner, the manufacturers are on the phone.
If you're still on the phone, please raise your hand because I can't see you right now. I'm going to let that question sit for a second because we're going to get through. There's a lot of hands raised, and I want to make sure we get a robust set of comments in before we look at the vote slide. Dr. Paling, sorry.
May I ask for this voting language slide to be put up? I was convinced about the importance. I recognize that long COVID is a big deal and is the risk goes down with COVID vaccine. And we also know MISC is a big deal in children. And we also know that there are many children that get hospitalized and into the ICU, and there is no risk factor. So for me, the best prevention is vaccine. And if the slides are up, I would like to make a motion. Thank you. And so I'd like to make a motion to accept the language as written. Thank you.
Thank you. Dr. Wallace, did you want to go ahead and read this slide out just in case so people can hear the language?
Yes, thanks, Grace. ACIP recommends the 2023-2024 monovalent XBB containing COVID-19 vaccines as authorized under emergency use authorization or approved by biologics license application in persons 6 months of age and older.
Thank you. Back to Ms. Bata, and then I see Dr. Pretty on the phone has raised her hand. So Ms. Bata?
I will second that motion.
Okay, thank you. We're going to pause for a second. Well, let me just say it's been moved and seconded that the proposed ACIP voting language that is listed on the slide and described by Dr. Wallace be the proposed vote for after public comment. I'm going to go to Dr. Pretty next.
Thank you. I just wanted to respond to the last question about supply. We predict that we'll have adequate supply. We don't anticipate there'll be any restrictions, and we're happy to give an official number offline when we can get that. Thank you.
Okay, thank you for responding. Dr. Long.
Sorry, take me a while. So so now we're discussing the real meat of this proposed language. Do I understand from this that this would include Moderna, Pfizer, and potentially Novavax without us discussing Novavax again?
Yeah, so the vote today would be Moderna and Pfizer because those are the two with products under emergency use authorization or approved by biologics application. But it would mean that we probably would not meet again for Novavax, though all of the available data have already been presented today.
So that really is a departure. I'm really very concerned about that. On one hand, we certainly want children 6 months of age and older, especially those young ones, to have the opportunity to receive this vaccine. And we certainly want vaccines other than a messenger RNA vaccine to be available. But the lack of data in children, a lack of any clinical data in children, and lack of data, in total, makes me concerned about particularly Novavax, which is adjuvanted, and I have not heard anything about this adjuvant from the work group. So I wonder if if Matt Daly could say something about, I don't want to hear more from the manufacturers.
Sorry,
Incidentally, the Novavax killed my email today. More than 300, please confirm Novavax. That's unprecedented for any of the other vaccines, and it doesn't actually help us. It makes it more difficult for us to do the good jobs we do when we're not on this call. So let's please stop that kind of activity. But I wonder, Dr. Daly, if you could tell us why you thought we could do this without further discussion.
Well, actually, I'm just going to jump in, Dr. Long, just to clarify. I just want to, my understanding from what Novavax presented is it would be for 12 and older is what is anticipated. So while this recommendation is to ensure consistency on the general recommendation with products that are available, I don't believe that necessarily means that there would be a brand new recommendation down to 6 months for a vaccine that hasn't been previously authorized or approved. But I'm happy to defer to my colleagues at the CDC and the FDA. And Dr. Daly, if you wish to respond, please feel free.
Well, I'm gonna respond in brief. Dr. Long, thanks very much for the question. Novavax has presented multiple times before the ACIP COVID vaccines work group. But in terms of public ACIP meeting, we're restricted to review and vote on the vaccines that have an EUA and have a BLA. And then the decision about whether to have another public meeting when Novavax receives approval from the FDA. I mean, I think that's not a work group decision. That's ACIP secretary, ACIP chair decision. So I think at that point, I'll ask for them to comment. Thank you.
Dr. Wharton.
Dr. Lee, this is Melinda Wharton. So the vote.
We just lost you, Dr. Wharton.
We're using a hand mic in the room and we're all having trouble with it. So the vote language as proposed, the intent of it is to cover for the upcoming season the XBB containing monovalent vaccines as they are authorized either under emergency use authorization or approved by BLA. There is, as has been discussed today, one product which according to the manufacturer remains under review and we anticipate will likely be authorized soon. The available information has been presented today. As far as I know, no additional information will be available that would be able to be presented at an upcoming meeting following regulatory action. So we certainly could reconvene the meeting. We always can reconvene ACIP if it feels necessary, but given the fact that no additional information is expected to be available, it feels like this is the kind of vote that we can move to a more normal cadence of things, such as we do for recommendations like for influenza vaccine, where we don't necessarily need to reconvene the committee when additional products are licensed under existing recommendations.
I would like to just follow up, Dr. Wharton and Dr. Lee, to understand that if FDA does not authorize Novavax for 6 months of age and older, that this will not be applied at, it says 6 months of age and older. And I would be very firmly against such a recommendation.
It would be, they'd be recommended as authorized. And our expectation is that it will be authorized for 12 years of age and older.
Thank you. Thank you. That's all I wanted to know.
Thank you. All right. I'm going to go to Dr. Duchin.
Thank you. Yes, I wanted to just follow up on the vaccine for adults discussion, which was incredibly valuable. Thank you, Dr. Twentyman. With tens of millions of underinsured adults who don't have access to the disease and life-saving vaccines that the rest of us have access to, we really have a huge problem in the U.S. This represents a burden of preventable illnesses, hospitalizations, and deaths that we really shouldn't be tolerating. So I want to reemphasize on behalf of the Infectious Disease Society of America, on behalf of the National Association of County and City Health Officials, that we need a vaccine for adults program. It's essential. And one of the things I'm curious about is whether we can see in the future a cost benefit or analysis or a cost effectiveness analysis about what we would gain with respect to prevented morbidity, mortality, and cost, and that maybe at some point in a future meeting. For this meeting, one question I have with respect to the Bridge program, where does the public get information on where vaccines for uninsured people will be available in their communities? Is there a centralized place where they can go to get that info?
Thanks so much, Dr. Duchin. There is indeed. Later this week, vaccines.gov will be updated to include a filter for Bridge Access Program site. In other words, all sites participating in the Bridge Access Program through which no-cost COVID-19 vaccines can be found. Thank you so much.
Wonderful.
Thank you. Dr. Cieslak?
Hi, thanks very much. I agree with what Dr. Duchin just said. I guess I just have a comment, and that is that I'm struck by the number of unknowns and the low certainty and very low certainty evidence regarding both efficacy and reactogenicity that were presented, along with widely varying estimates of risk by age and underlying condition. That I'm surprised at the recommendation for a universal recommendation. I would think that a shared clinical decision-making recommendation for most groups would be more consistent with the state of the science at this point in time. Thank you.
Hi, this is Dr. Wallace. If I could just offer some clarifying remarks. Whenever grade is applied to observational data, the evidence certainty always starts at low certainty. So whenever these vaccines were all first graded back, whenever they did the large RCTs with the monovalent, those were all high certainty data because they started as RCTs. So part of the grade interpretation has to do with the fact that we are now looking at observational data instead of randomized control trials.
Thank you. We're gonna move to Dr. Rockwell.
Hi, thank you. Pamela Rockwell, family physician representing American Academy of Family Physicians. My question is about clinical guidance, just anticipating questions I'll get from my patients. If somebody received the bivalent shot within a week or 2 weeks, what do I tell them about getting this new 2023-2024 vaccine?
We're recommending a 2-month interval. So 2 months from your past dose, you can get this vaccine.
Thank you so much.
Dr. Fiskus.
Hi, thank you. I'm Michelle Fiskus. I'm representing the Association of Immunization Managers. I have a question, maybe Dr. Peacock can answer, it might need CMS. If an individual covered by Medicare is going to get co-administered RSV, COVID, and flu vaccines, do we know if it will be permitted for that provider to bill both Medicare Part B and Part D on the same day? And also if Moderna can comment on when the pediatric vaccine will be available from Moderna. Thank you.
Hi, thank you, Dr. Fiskus. I think we have our CMS liaison on the line, and they'd be better to answer that. Thanks. We'll get back to you on that. Thanks.
Would you like me to respond for Moderna?
Sure, go ahead, Dr. Priddy.
Okay, hi, that's Fran Priddy. Yes, so we've tested our vaccine, our prior versions in children, as I mentioned before, and are in the process of accumulating the required safety follow-up needed to file for licensure. And we anticipate doing that in the first part of 2024.
Okay, thank you. Dr. Fiskus will ask if our CMS colleague can comment later, but for the next 3 hands raised, I'm just going to ask our ACIP members if you could provide any comment, ask any questions you have, but also please give us your thoughts around the proposed ACIP voting language on the table, just so we can make sure we have a robust discussion around this. Dr. Lair.
So thank you. My question is regarding immunocompromised people. We currently have a recommendation that they can get a booster dose 2 months after they get the dose. Have the people writing the clinical considerations given any thought to what they're going to recommend going forward with immunocompromised people?
Hi, this is Dr. Wallace. So our planned clinical considerations for persons with immunocompromising conditions will be really similar to what they are for the bivalent dose. They will just be traded out. So if it's an immunocompromised person that has not been vaccinated, they will they'll be eligible for an initial COVID-19 vaccine series. For those that have previously completed an initial series, they're recommended for at least one 2023, 2024 COVID-19 vaccine dose, and they may receive one or more additional doses as well.
Just to clarify, the prior recommendations for immunocompromised still stand under this recommendation?
Yes, we'll just be switching out the formulation.
Oh, I see. Okay, the last bullet. Thank you.
Thank you.
Dr. Lair, did you have another question or comment?
No, thank you.
Okay, thank you. Dr. Brooks?
Yes, thank you. First of all, excellent presentations, the ETR and Dr. Peacock and Dr. Twentyman. Thank you, Dr. Wallace. I think we have all the information that is available. So this is what we have to make the decision. I put on more of an influenza hat because though this is the first year, there's the potential that we'll be doing this every year in terms of evaluating a new vaccine or the concept of a new COVID-19 vaccine. So when we do influenza, we don't review it every year and look for all the data that we're talking about. This is what we have. We have a major illness. We have to do something. I'm fully in favor of it, of the universal recommendation. I think that the long COVID data for post-COVID conditions is compelling. And we don't have a lot of data in the children, but in terms of universal, it's likely it'll be a benefit. Feel good about the fact that in the bivalent, we saw no signal for myocarditis, very important. In terms of equity, African Americans, even from younger ages, have higher incidence of underlying conditions, which would lead to higher adverse events in terms of hospitalization, ICU, and death. So definitely the vaccine needed. And lastly, the lowest recommendation rate from healthcare professionals to get COVID vaccine. So that's something that we need to work on. But in the end, this is the information we have. The virus is out there, it's mutating. We saw data from at least one of the vaccines that shows that they have neutralizing antibodies against the XBB 2.86. So fully in favor of a universal recommendation.
Thank you, Dr. Brooks. Dr. Sanchez.
Yes, just wanted to add some comments here. I'm not for a universal recommendation at this time. I certainly think that those the elderly adults, whether 65 or greater than 55, I would recommend that, as well as certain risk groups, certainly the immunocompromised in pregnancy. But I think that we need to be aware and let the public know that the data on children is not there. And for that, I think that discussion needs to be had. So I think in non-high-risk groups, I would favor a shared decision-making. And even the concern for the 12 or 15 to 39-year-old, the myocarditis risk, I recognize that it hasn't been seen with the bivalent dosing, but the uptake has been low for that as well. So I think we need to be, we really need to level with our patients and say what is known and unknown rather than make a complete recommendation, especially for some groups that there are limited data. Thank you.
Thank you, Dr. Daly.
Yeah, thanks so much. I think I have a couple of comments, but I'm going to try to directly address Dr. Sanchez's comment about sort of the amount of data. I think This is a complex and subtle point, but I think we have quite a bit of data, including quite a bit of data about the use of these vaccines within kids, but then that data is based on prior monovalent and prior bivalent. So it's not a total absence of data. When we say limited data, it's limited data of XBB.1.5 as a strain. So I think that's a little bit more, I realize it's complicated, but I want to make that point. So a couple important points of context I want to provide. First, as our colleague Dr. Talbot's mentioned at prior ACIP meetings, once a vaccine is universally recommended on the schedule, it's difficult to change that policy decision. So I appreciate that. I want to mention that. Second, based on some feedback that we've received, there was some concern that the work group entered its deliberations this summer, assuming that a universal vaccination strategy was the obvious policy choice. But I just want to reiterate that that was very much not the case. The work group reviewed this as an opportunity to reevaluate the vaccination program, and we essentially started with a blank slate. And so related, the work group asked our CDC colleagues to update and present data on disease burden by age group for those with and without chronic medical conditions. And that was the most persuasive line of argument for me, knowing that there were deaths, including in children, including in those without chronic conditions. And my perception is that those deaths are vaccine preventable. And when we asked for this burden data, the focus was on serious disease, including hospitalization, ICU admission, and death. And Dr. Wallace summarized all this for us. And suffice it to say that the disease burden does vary greatly by age, but there is serious illness, death across all age groups, including among those without underlying medical conditions. So there may be a day where we revisit a risk-based strategy. We always should consider this. But in order for that to be a desirable approach, I think we need to feel confident that disease burden in those not at risk would need to be quite low. And that's low in absolute terms of cases of serious illness and death, but also low in relative terms, relative to the burden of disease for other diseases against which we have a universal vaccine recommendation. Thanks.
Thank you, Dr. Daly. Dr. Sineas?
Thank you. I just wanted to say that I agree with a universal recommendation for all the reasons that Dr. Brooks listed, in particular in the realm of equity. I just do not feel that a shared decision making recommendation promotes equity. I feel like it would lead to more disparities. So I'm in favor of the voting language as it stands. Thank you.
Dr. Bell?
Yes, thank you. I just wanted to sort of, add in my perspective. I agree with what Dr. Daly in particular said, and I just want to first of all say that, my responsibility, my job is to give the best advice given the current data and circumstances, and so that's what I'm trying to do. I think today we've heard a wealth of evidence about the risks, the benefits, extremely comprehensive dealing with the issue. And to Dr. Daly's point, I think that it indicates there's all kinds of robust information that show robust benefits of vaccination on severe illness, on death, probably on long COVID. And so with a reasonable safety profile, granted not exactly with this vaccine, but with, a very, very similar vaccine. So I think that it's clear that vaccination is going to prevent serious illness and death across all age groups. It is a vaccine preventable disease. And so I, for that reason, favor universal recommendation. Now, having said that, because I think it's important for people to have access to the vaccine if they want it. Having said that, I also want to say that there's not equal risk across all ages and populations. And it's clear that there are certain people, like old people like me, people with underlying medical conditions, that are at much higher risk of dying. And so I think that the messaging needs to sort of clarify that and make clear that that there is this differential risk and that a lot of people with underlying medical conditions and who are older are dying, and they really need to get a booster. And then the last thing I'd like to say is about the equity issue that Dr. Sineas just raised. And I agree with her that shared clinical decision-making does not promote equity. And I also want to congratulate the CDC on the Bridge program and these efforts to sort of deal with the fact that we don't have a vaccines for adults program. But I think that we have to continue to work hard day after day, not just the ACIP with our recommendations, but everybody who's working in this space to continue to promote equity, because we continue to see that these disparities continue to exist and are perpetuated. And we just really, I think that is just such a high priority. I wanted to just make that point again. Thank you.
Thank you. Dr. Long.
Yes, I've been very grateful for Dr. Daly and Dr. Bell's insights and sage advice. And I was going to want to go down the path of risk-based because I am concerned mainly that if you just recommend it universally, it's as if game as usual, when we really want to emphasize those who are at risk of death. And I was thinking maybe the best way to do that would be to be risk-based with a permissive for everybody else. And I suspect that Dr. Bell thinks this would work better to recommend it for all, and then somehow be sure that the group who really is at risk of high risk of death, the elderly, the obese, those with underlying conditions, those who are immunocompromised, and children to 6 months to 2 years, and by extension, under 6 months, whose mothers need to be I'm not still quite sure how the best way to get our best intentions implemented into action and for people to take up the vaccine. So I'm swaying toward thinking universal may be the best we have, but it's not good enough, because I think we'll recommend it and nobody will get it, or the people who need it most may not get it, and especially the groups for whom we're concerned about equity. Thank you.
Thank you, Dr. Nelson. Dr. Cotton. I always do that to you. Sorry, Dr. Cotton.
Thank you. As a very active adult infectious disease specialist who sees many patients, inpatients and outpatients, I have been astonished at the number of people who have not been vaccinated. We need to make vaccination recommendations as clear as possible. Shared clinical decision-making will result in major problems with equity, and I'm strongly in favor of a universal recommendation, providing clarity and hopefully confidence in the CDC and other US government bodies, including the FDA. But let's keep America strong, healthy. Let's do away with COVID-19 as best we can by prevention of disease through vaccines. Let's make things clear. That's my vote. Thank you.
Thank you. I'm going to go to Dr. Lair.
Thank you. I have immense respect for Dr. Sanchez's position, and I understand where he's coming from because I'm often hesitant about universal recommendations. But in this case, I'm very strongly in favor of it. I'm impressed that the work group reviewed the data from scratch. I'm impressed with the economic benefits. I feel that the overwhelming benefits of recommending it for everybody and making it a simple recommendation will outweigh the complications that would happen with a shared decision-making or risk-based recommendations. So I too am in favor of the universal recommendation. Thank you.
Dr. Wharton?
Dr. Mann would like to make a comment about communication strategies.
Yeah, thanks so much. And sorry, this is in response to Dr. Long, and I'm sorry we had a little trouble putting our hand up. But I just wanted to say that we're very mindful of the groups that are at substantially higher risk and are planning targeted communications to try to have vigorous and compelling outreach to those groups. That can be done regardless of whether a recommendation is targeted or not. So under a universal recommendation, we will still have targeted communications for older adults, immunocompromised persons, and others at higher risk. Thanks.
Thank you, Dr. Hopkins.
Thank you, Dr. Lee. And I want to thank, on behalf of NFID, I want to thank ACIP for its diligent work to ensure the availability of these safe and effective vaccines. I think our challenges of communication and of getting these vaccines into arms and protecting our adults and children in our society are going to be important as we move forward through these recommendations. Although the rates of hospitalization and death due to COVID-19 remain low compared to pandemic levels, certainly COVID-19 remains a significant public health problem, and transmission is increasing with the recent emergence of the different variants. As this new monovalent vaccine becomes available this fall, it'll be essential for all of us to work collaboratively and collectively to increase immunization rates and reduce the burden of disease, and also to be responsive to questions and concerns about the multiple different respiratory virus vaccines we're going to need to use. You know, our respiratory seasons are notoriously unpredictable. And while it's not possible to predict the severity of this upcoming season, we do know that planning and preparation are critical, as are the right messages and messengers to strongly encourage folks to provide clear guidance on vaccine timing and on the public health messaging. And again, I thank you for your time, and NFID will continue to partner as we close our 50th year and continue to move forward in support of better public health through vaccination in the future. Thank you.
Thank you. Dr. Freihofer, did you have a quick comment?
Yes, I just wanted to point out that in Dr. Wallace's slide 22, half of the children who died had no underlying conditions. There is no group that clearly has no risk from COVID. And even children and adults with no underlying conditions can still experience severe illness due to COVID. And we're at a point now when vaccine and infection-induced immunity is beginning to wane. We have these new variants that are emerging. We're all becoming more susceptible. This will likely increase in time, and we're sort of seeing that. This new vaccine will increase the immune response against circulating variants. Today's discussion makes me very confident of that. This new vaccine will help protect us from COVID, and I really encourage ACIP to vote for a universal recommendation for those 6 months and older.
Okay, thank you. I just have one last comment I just wanted to express as a member. So I also feel, reviewing the data today, that the benefit risk balance makes sense for people 6 months and older, with the greatest benefits in the oldest and the youngest. So then for me, you know, much of the decision from there rests on cost effectiveness, implementation, and equity issues. And I'm just going to highlight a couple of equity issues that I think are important to highlight. So on the equity front, first, our healthcare delivery system in the US continues to have structural inequity built into it that functionally makes access to care more difficult for some compared to others. And I believe this is different from the situation in other countries where healthcare coverage is universal. Second, our vaccine financing system, which is a public-private partnership, inherently relies on healthcare providers and some in small practices to carry the financial burden of vaccine purchase without assurances that they'll be able to be fully reimbursed for their costs or for doses that go unused in multi-dose vials. So there is risk to providers delivering these vaccines, despite the immense benefit they can provide to our patients. So if we make complex and nuanced recommendations, I believe we're adding burden to our health systems and to our providers, which in turn I think will unintentionally add to existing inequities. So I really wanted to strongly endorse the universal recommendation for that reason. I also want to recognize and laud CDC for doing everything within their power to ensure that these gaps are minimized, and doing this well in advance of a recommendation. It's not a long-term or sustainable solution, and certainly not one that can extend to other critical vaccines that we also need to protect our patients and families. But you know, I recognize this is not a problem we're going to be able to solve, but I do think that we are making the decision today for the US, given the context that we're in. Other countries might end up making different decisions because their context differs entirely. But because access to vaccines is so critical and there continue to be disparities, I feel strongly a universal recommendation is indicated. And with that, I'm going to give our team just a 3-minute break. So we'll meet at 45 minutes after the hour. Come back for public comment, and then we'll move into the vote shortly after that. Thank you, everyone. Thank you, everyone. I'm gonna move us along and thank our public comment speakers for joining us today. We're about to begin oral public comment. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period. In order to make it through all the list of speakers, we ask that each speaker limits his, her, or their remarks to 3 minutes. We do have a timer displayed on the screen, so you know how much time you have left. I also want to just highlight that while we had, well over 130 people who requested to speak, I don't know if we went long over or what happened, but we have one public comment speaker with us today, and we very much look forward to your comments. So I invite Dr. Melanie Matthew to please go ahead and provide public comment.
Hi, thank you so much. Good afternoon. My name is Dr. Melanie Matthew. I've published and worked in the field of immunology for over 2 decades. Very quickly, for disclosure purposes, I am a founder of a company, but there's no financial interest in the outcome of the decisions made today by ACIP. For the last 3 years, I've used social media to teach about the SARS-CoV-2 virus, vaccinations, variants, and communicate many of your guidelines to hundreds of thousands of people. So I'm delighted to be here today, and I'm very heartened to hear all of the recommendations for universal vaccine rollout. That is what I'm here to talk about. I really feel strongly that all people of all age groups for which the FDA has approved this vaccine have access to this vaccine. There's been a lot of discussion about children today, and I understand that the data pool is not what we would hope for there. However, children, although they do suffer from less COVID-19 morbidity and mortality, there are numerous examples of lifelong morbidities associated with SARS-CoV-2 infection in children, including higher rates of higher rates of new onset type 1 diabetes, and numerous case studies showing significant cardiac issues, including necessitating pacemakers being placed in previously healthy children, all post-SARS-CoV-2 infection. And as long as this vaccine is deemed safe, I do not understand why it would be withheld from that population when it could have a significant impact on lifelong morbidity and allow a child to live a healthy life. We also tend to forget that children do not live in a bubble. They're often part of multi-generational households. They see teachers daily, and protecting children from significant bouts of infection and reducing duration of infection also protects people writ large. I'll make two more brief comments. I actually don't see the timer, so feel free to cut me off. But you know, COVID-19 sequelae is significant, and it's correlated with severity of disease. And severity of disease, we know well, is reduced by vaccination. Post-acute sequelae from SARS-CoV-2 also shows up not after first and second infections, but often after third, fourth, and fifth infections. There is literature evidence that damage accumulated from SARS-CoV-2 infections is cumulative with each infection. So although many people have been exposed to viral antigens through vaccination, infection, or both, you can see physical damage being cumulative in the population, and increased mortality 6 months out has been also demonstrated in the literature. So we do know that vaccine protection wanes and can be significantly eroded by changes in the spike protein.
15
so
seconds.
Again, oh, sorry, am I over?
Just 10 more seconds. Please go ahead.
10 more seconds. All right. Well, thank you so much. I just wanted to say that I think it's abundantly clear that we need updated vaccines on a yearly basis at a minimum. And it would be unprecedented to restrict access to an approved vaccine that limits potential lifelong illness and disability.
Thank you for your comment. Appreciate it. I'm sorry you could not see the clock. We will I would just want to thank our public comment speaker, and also thank those who take the time to submit written public comments via the CDC docket. We had over 15,000 written submissions, and certainly have heard the voices of the public on the issues at hand. With that, we are going to move to our vote section of the meeting. So I'm going to ask our colleagues in the room to please put up the proposed ACIP voting language that is up for vote. So any other questions, clarification, comments people would like to make before proceeding with the vote? And I will remind my colleagues that we do need to put our screens on for the vote. I don't see any hands raised, but I am seeing screens. So thank you everyone for joining. There might be a few others who I think are in the middle of clinical services. If you're able to join us on screen, that would be wonderful. Okay. Well, we will go ahead and it's been moved and seconded that we accept this vote language. So I don't see any additional hands raised. We'll go ahead and I will call on individuals to please vote, and please remember, state your name, whether you have any conflict of interest in your vote. We'll start with Dr. Bell.
Beth Bell, no conflicts, yes.
Thank you. Dr. Cotton?
Meal Cotton, no conflicts, yes.
Thank you. Dr. Long? Okay, we'll come back to Dr. Long. Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Thank you. Dr. Lair?
Jamie Lair, no conflicts, yes.
Thank you. Dr. Paling?
Kathy Paling, no conflict, yes.
Thank you. Dr. Sanchez?
Pablo Sanchez, no conflict, no.
Thank you. Dr. Talbot?
Dr. Talbot, no conflicts, yes.
Thank you. Ms. McNally?
Conflicts, yes.
Thank you, Ms. McNally. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Ms. Bata?
Lynn Bata, no conflicts, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Oh my goodness. Okay. Dr. Long?
Thank you. I'm sorry, I had some noise going on here. Sarah Long, no conflict, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Lee, no conflicts, yes. Are there any members I didn't call on since I went completely out of order? Okay. Dr. Wharton? I think I have 14 yeses and 1 no.
Well, 13 yeses and 1 no.
13.
There are 14 members of the committee.
Thank you. Thank you. So the motion passes as proposed. And with that, we will open up for comments from our voting members as well as our liaisons if they wish to make any public comments about the vote. So Dr. Talbot, I see your hand is raised.
I have a couple quick comments. I'm going to reinforce vaccines for adults over and over and over again so we can get rid of this inequity and improve vaccination rates for all adults regardless of age. The second thing I want to highlight is something that Dr. Daly mentioned, is that we are still learning about COVID and this data is going to change all the time. And so I think we need to constantly reevaluate. We actually don't know when the COVID season is. So fall may not be the time for us to be voting on and recommending vaccine. It may be spring. So I just want us to remember that and to reevaluate continuously and vaccines for adults. I'm done. Grace, you're on mute.
Thank you. No wonder why Dr. Sanchez couldn't hear me.
I was wondering if I was next. No, as voting against it, I just want to be clear that I am not against this vaccine. The data do look great. The limited data that are available does look great, even though it may not be the most, the circulating variants currently, but it has neutralizing activity against the other variants, and certainly the ones that are circulating now or expected to be circulating. I am very much pro vaccination and certainly high risk groups. I just want to comment that we have extremely limited data on children and infants and other individuals, and so I think that needs to be made available then to the parents. And I also think that in certain circumstances, we do have to be concerned about potential side effects, especially in the in young adults and young adult males. And so I think all of that needs to be weighed. And so that's why I hesitate to make it just a universal recommendation, even though I do support vaccination with the COVID vaccine. Thank you.
Thank you. Ms. McNally?
Thank you. I really just want to emphasize for consumers that it's very important as they consider this particular vaccine that they talk with their healthcare provider to make sure that they have all of the best information possible to make a decision to protect themselves against this circulating strain and other strains of the COVID-19 virus. Thank you.
Thank you. Dr. Lair?
Thank you. My office staff just asked me, and I think it's probably useful for the entire country to now be reminded that the bivalent vaccine is no longer recommended. And so it should not be given and should be taken off the shelves and put to the side. They were thinking that they were going to be giving it until we got the new one in, but I understand that by this vote, we're recommending not to use the bivalent vaccine anymore. So that's important for all the offices in the country. Thank you.
Thank you. And then just to clarify, I think from the FDA authorization yesterday, the bivalent vaccine is no longer authorized by FDA. Thank you. Dr. Duchin.
Thank you, Dr. Lee. I just have a brief statement on behalf of the Infectious Disease Society of America. IDSA supports that ACIP's new recommendation makes COVID-19 vaccines available to all persons 6 months of age and older who choose to be vaccinated. Most importantly, we strongly encourage the updated 2023-2024 vaccine for all persons who are at increased risk for severe COVID-19, including everyone 65 years of age and older, and the many adults under 65 years who have one or more underlying medical conditions that place them at increased risk for severe infections. Thank you.
Thank you, Dr. Duchin. I don't see any hands raised. Last call. All right, well, with that.
Oh, I'm sorry. It's Dimitri Daskalakis. One very quick last call. So I just
Sure.
wanted, I apologize. It's the hand mic and our speed in turning it on. I apologize. So first, I want to just say thank you to everyone on the committee for all the amazing work and just a really rich discussion. I think this is sort of where the magic of ACIP is, that after all of the thought and all of the discussion and such a clear process to go from data into recommendation, it's so inspiring to see the process and to hear the voices and to hear opinions in all directions. And I just also want to give a very specific and loud shout out to the NCIRD staff that works so hard to make sure that all of this magic happens and supports ACIP and all the work that they do. So I think that just thinking about the importance of this discussion and the importance of the decision in protecting Americans from severe manifestations of COVID, this process, its transparency, and just the amazing thought and work that has gone in from every direction is really inspiring. And I don't want to keep you anymore from the rest of your day, but I just wanted to once more say thank you so much for all the amazing work.
Thank you for those comments. And I want to just echo my thanks to all of the speakers and all of our ACIP ex officio and liaison members for your work today and for your ability to come together for somebody's going to count for me, but I think our 34th meeting since the pandemic. With that, by some miracle, we have ended on time. So I thank you all for your efficient, thoughtful, robust discussions around this issue. We certainly appreciate it. And I know the public appreciates being able to hear the deliberations. That this is not an easy decision, but one that has been really at least well considered from all different angles about how we get to the decisions we do. So thank you again. We look forward to seeing you soon. Have a great day.